go. All right. Shall we get started? Yeah? All right. Welcome, everybody. Hi. I'm Marcus Goldstein, Vice President at the Center for Global Development. I'm relatively new here. I joined about 3 months ago, but I've spent my whole career working on the core mission of the center, which is generating and sharing actionable evidence to improve policy. Some of you in the audience will know us well, but others won't. So by way of introduction, CGD is a nonprofit, nonpartisan, fiercely independent think tank that brings rigorous evidence to bear on global problems. It's really exciting to see such a full room here for the same reason, which is generating and sharing rigorous research to help inform our global response to such an important global issue, lead exposure. I wasn't here when the work on this started, but I've seen pictures from that working group on global lead exposure. It was about 20 people representing the key people and organizations, or a plurality of the key people and organizations who were working on the issue at the time. It's amazing to see how much it's grown. We were just talking as we were waiting for this to start about how it's turned into a movement. Okay, I imagine I'm preaching to the choir here, but let me share some motivating headline data points about global lead exposure that motivated CGD to take on this issue starting about 4 years ago, and I think have been part of why we've seen such a great response. First, we learned from seminal work from UNICEF, IMHE, and Pure Earth that 1 in 3 children worldwide had blood levels exceeding 5 milligrams per deciliter, the level at which the WHO recommends clinical intervention. Almost all of these kids live in developing countries. There's a great poster with this data right outside. Second, from our own research at CGD, we found that lead exposure could explain about 1/5 of the learning gap between rich and poor countries, which is, for people who work on education, that's a huge amount. And third, while the neurotoxic effects of lead are long established, an emerging body of research documents effects of lead on other bodily systems, in particular the cardiovascular system, suggesting that lead may rank among leading contributing factors to global mortality. Also on a poster outside. So if you haven't seen the posters outside, they're more interesting than me. We've come a long way in this journey, and I'd like to make a couple of acknowledgments as part of that. First, our co-host, the Partnership for a Lead-Free Future, or PLF, which is the first ever global public-private partnership dedicated to tackling lead poisoning in low and middle income countries, counting 30 countries, 21 NGOs, the world's largest multilateral organization, and development banks, and major foundations among its members. The PLF is helping lead the global response, and CGD was incredibly proud to join the PLF last year as a founding member. And we're delighted to help advance the research agenda to help make their work as impactful as possible. Second, I want to thank the funders who've supported this work and helped make this conference possible. In particular, I'd like to thank Open Philanthropies Lead Exposure Action Fund and Founders Pledge for their contributions to this conference, as well as GiveWell and an anonymous funder for supporting prior work. Now I'm going to turn it over to the driving force behind this work at the center, Rachel Bonifield, who's going to lead you through the rest of the conference. Rachel's our Director of Global Health Policy and a Senior Fellow, and she's been doing this amazing work. So Rachel, over to you.
All right, thank you, Marcus. And thank you to all of you for making the trip to be here today. It is incredible to see so many familiar faces. It's, I'd say, equally incredible to see a lot of unfamiliar faces and to know we've been able to convene so many people in this room, some of whom are new to the community, some of whom have been working in this space for a long time, but perhaps it's your first opportunity to connect with this broader group. So to old friends and new friends alike, welcome. We're really glad to have you here for the next few days of discussion and events. So I'm Rachel Bonifield. I'm the Director of Global Health Policy. I'm a Senior Fellow here at CGD. I've helped lead our work on global lead poisoning over the last 4 years, and I'm delighted today to be able to conference on lead exposure at CGD. Hopefully we'll have the slides up shortly. The first thing to say is that we see research as an essential part of what the lead community has needed to get motivated and to form a response to these issues. So research has already powered the historical fight against lead poisoning. Starting in the 1960s, documentation of widespread lead contamination drew attention to the impact of leaded gasoline, and that helped spark a global successful movement to get lead out of petrol. Research has demonstrated the subclinical effects of long-term exposure to lead. We used to think it was only important when people had acute lead exposure, but increasingly research over many decades showed that even at very low levels of lead, lower and lower than we initially thought, the neurotoxic and cardiovascular and other effects are present. There is no safe level of lead. This is a research finding that has now inflected our overall approach to policy. Extensive source apportionment research has identified lead in a host of consumer products and as industrial contamination. So we're using research to find new places where lead is hurting people and to try and get that lead out. And it's also helped to power technological development that has made it possible to have a lead-free future. So research into petroleum refining found ways to do so without using lead as an additive. There are lead-free pigments that we could have in paint, so there's no need for lead pigments anymore, and all sorts of other products, and this has facilitated the removal of lead from many historic applications. Recently, recent findings have refocused attention on this issue. I think there was a wave of research in the 60s and 70s that led to an initial range of initial movement against lead exposure, although often concentrated more in high-income countries. But recently, we see how extensive a problem this remains, particularly in low and middle-income countries, and why it's so important to have a global response to this issue. So as Marcus was sharing already, 1 in 3 children globally are estimated to have blood lead levels above 5 micrograms per deciliter, the level at which the WHO recommends clinical intervention. They are overwhelmingly concentrated in low and middle-income countries. Every year, IHME estimates, and the World Bank estimate, that somewhere between 1.5 million and 5 million deaths can be attributed to lead exposure as a risk factor for cardiovascular disease. Now, it's not the same as malaria. It's not, you get a parasite and it directly kills you, but those numbers are enormous. It ranks, it starts being in the same echelon as tobacco, for example. Not quite, but same general echelon. Those are very big numbers. We've learned from research at CGD that about 1/5 of the learning gap between rich and poor countries can also be attributable to lead exposure. So it's not just a health issue. It's not just an environment issue. It is an education issue. It is a development issue. It is a growth issue. It is about putting the entire countries and economies on the track to a prosperous, thriving, safe, healthy future. And this is happening at the national level too. So in Mexico and Georgia, for example, national surveys alerted policymakers to the issue. And all over the place, there has been identification of new sources, spices, cookware, that presents new potential for highly cost-effective interventions to mitigate the burden of lead. This has motivated a global mobilization. So we've already had a shout out to the Partnership for a Lead-Free Future, and we know many of you in the room are members of that partnership. The World Bank, who we'll hear from more as well, has also taken this on as an issue that they're advancing in partnership with their member countries. There are also many domestic efforts, such as India's Lead Elimination Action Partnership. We'll hear more about this shortly. And there is $104 million to be channeled through the Lead Elimination Action Fund for measurement, mitigation, and mainstreaming. This is a multi-funder pooled fund led and operated by Open Philanthropy, that's really helping to scale up some of these efforts that we have identified as being highly cost-effective and important public health and development interventions. But as we try and do this, as we try and scale up, as we try and implement the interventions that we hope will mitigate this burden, there are still key questions that we need to answer. The first is around sources. Yes, we have identified additional sources. We know more now than ever before about where the lead is coming from, but we still don't know nearly enough. And on a country-by-country basis, on a community-by-community basis, that looks different. So research is still needed to identify where lead is coming from so we can intervene to stop it. A second is impacts. What effects does lead exposure have? Yes, we know lead is bad. We know lead is bad in a million different ways. That's not on the table and controversial. But as we're finding new avenues and we're learning more and trying to pin down exactly how bad, for example, it is for cardiovascular disease, what the dose-response curve looks like, in what phase of life it's most impactful, there are all these unanswered research questions that we don't yet have the answers to. And then finally, interventions. We're trying to go out in the world and mitigate lead exposure. How? What actually works to reduce lead exposure? We know some things are impactful. We have a lot of evidence, for example, with reformulating paint. But for some of these newer sources, for some of these emerging issues, we don't yet have an effective playbook, and we need research to evaluate interventions to attempt to do so. During all of this, the methods we have at our disposal are evolving. We have methods for several different kinds of things. We have methods for testing lead in people, blood lead testing, or there's other more emerging types of testing around testing bone for cumulative lead exposure. We have techniques for testing stuff, to seeing the lead content of actual things, spices, paint, dust, dirt. We also have statistical methods that are evolving, and where we are trying to pin down the best way of doing things that is rigorous, that's scientifically valid, that is where our instruments are validated, where our approaches are sound, and where ideally we can then pool and compare results against each other to make every research study and the collection of them more than the sum of their parts. These are a couple of papers we put out last year trying to survey the landscape on that. So what are we doing here at CGD? We are attempting, and I hope successfully, given the size of this room, to support a lead research ecosystem. What we found when we started out is that lead as an interdisciplinary issue does not always have a natural home. It sits between environment and health and education and development and industry and consumer protection and food safety. There are so many different fields that have an equity in this issue, and without a dedicated home to bring these together, the community may not be sharing all the relevant findings and moving forward in the most impactful ways. So we are trying to create that home. We have a few different things we're trying to do as part of that. As you may have seen, we issued a request for proposals earlier this year related to research on lead poisoning, and we are shortly to award the first organizations in that space for the first research projects. We've organized roundtables and working groups on key current issues related to lead poisoning, featuring policymakers, funders, and researchers. We disseminate a bi-weekly newsletter for the community working on lead poisoning. If you're not already subscribed, Theo and Rory want to raise your hands. Yes, they're in there. If you are not already subscribed, but you would like to be, just hand your business card to one of them, and they will make sure you get on the list. We also do a monthly virtual call, which you are also all invited to, where we present research findings in progress and have a chance for the community to connect around them. So we welcome all newcomers to either of those processes. We're also open to suggestions. So we'll be here. Talk to us if there's something useful we can be doing in this space to help advance and even strengthen further the ecosystem here. But to preview the conference, we have 2 rich days of lead research ahead of us. So I hope you all are ready for quite a lot of significance levels, and we're really going to dig into the weeds. We have an opening policy panel, but right after that, it is into the research, and there's a lot of meat to dig into. And I think this is a room with a lot of researchers and people interested in research, so hopefully this is all red meat for you. So to give a bit of a preview of what we'll be doing, there is going to be panel sessions of 60 to 90 minutes. Each of them will feature 3 to 4 speakers and a moderator. We'll have a chance after the presentations for a moderated Q&A, so we'll have time for group questions. We will also have plenty of breaks for networking, poster presentations, and community building. We see that as a key part of the value of this conference, not just what you learn in here watching presentations on stage, but what you learn from each other and the connections you forge out there. So if it makes more sense for you at some point to skip a session and have a chat with someone you want to work with, feel free. We welcome people to use this conference and this space, however is most impactful to you. So just to give you a bit of a preview, we have 36 presenters from 16 countries coming up on the agenda. We'll have 3 sessions today. The first, which we're about to kick off, is on the status of policy on lead poisoning. The second will be new evidence of the impacts of lead poisoning. And the third will be methods and practice of lead surveillance. Then tomorrow morning, we'll reconvene. Oh, and then after that, we will have a reception. So we hope you will stay to mingle over drinks and snacks of your choice. Then tomorrow, we'll reconvene. We'll start in the morning with a session on paint and batteries, some of the better established sources that we've been aware of for quite a while, but where we still have some challenges in addressing the issue. We'll do a session on emerging sources, so some of the sources that are less well known, but research is starting to shed a light on. We'll have a poster session. So the posters are up. You are free to peruse them at your leisure. But we'll have a dedicated lunch and poster session where we ask all the poster presenters to be at their posters and prepared to talk to people coming by tomorrow. Then in the afternoon, we'll have something on understanding supply chains and incentives, a session on evaluating mitigation interventions, a session on national experiences, assessing and responding to lead exposure, and finally, the role of funders in addressing lead poisoning, a wrap-up policy session where we reflect on what we've heard and what it means for funding and policy. So we are quite excited for this agenda. I am personally excited to have a chance to connect with all of you. And with that, let's kick off the first session. So I'd like to welcome our panelists to the stage, if you can come on up with me. Brilliant. All right, wonderful. So we are privileged today to be joined by 3 esteemed panelists. First, we have Abhit Solomon, who is a senior advisor for environment at UNICEF, and he is here today representing the Partnership for a Lead-Free Future, our co-host for this event, where he has played an instrumental role in establishing, his leadership on the Toxic Truth Report, along with others at UNICEF, Pure Earth, and IHME, really was instrumental as the spark that helped kick off this movement on global lead poisoning and raise the alarm for us all to pay attention to. So welcome, Pete. Second, we have Tayo Adedeji from the World Bank. Tayo is the lead for pollution and circular economy within the Global Environment Department at the World Bank. And the World Bank has been a pivotal member of the PLF. They have really embraced lead mitigation as core to their business, and we're delighted to hear more about your work helping lead that mission. Finally, we have Dr. Indu Bhushan, who is the chair of the India Working Group on Lead Poisoning, convened by the Pali India Foundation. Previously, he was a long-serving senior official in the government of India, where he served as the first CEO of Ayushman Bharat, a flagship health program that provided healthcare coverage to low-income Indians. So, welcome to you all. We are very grateful to have you here. So we'll kick off with some opening remarks from each of you. Maybe I'll start with Pete. Can you maybe tell us, where do we stand in the global movement to address lead poisoning? How did we get here? What's happening? And what challenges are you seeing? And what's the response of the PLF? Over to you.
Thank you, Rachel. And maybe from a UNICEF standpoint, to first start by congratulating Center for Global Development, to you, Rachel, as well for your stellar leadership on this issue and for putting together this amazing research agenda for this 2-day conference. I think the clapping that we had immediately after Rachel's presentation was a bit feeble, so I'm going to just clap for you once again for the fantastic work. So, I think the congratulations also to all of the partners that are here today. I think it speaks to that global movement we heard about right at the beginning. I think that's what this signifies, and we've been sort of snowballing into the numbers and people that we see here today. So going back to your question, and actually you did capture some of the things I wanted to say, but I'd like to break things down into like 4 distinct phases in terms of how did we really get here. And I would like to first acknowledge that the issue of lead was there for a long time, for decades, actually. And if you, one of the things, if I look at from a multilateral perspective, I saw a report from UNICEF and UNEP back in 1990. It was Children and the Environment. And the report spoke to the issue of lead poisoning. So that is, you're talking about 1990, as far as then talking about what LMICs need to be doing. This report was signed off by the executive directors. And what we saw was all the appreciation to the great work we had in the source-specific era. And I think that era is still relevant and important. But I think the global partnership on the elimination of lead in fuels, which was huge congratulations to the public and private partners that came together. The US government played a very important role there. We achieved massive progress. I mean, the elimination of lead in fuels, you come to think of it, what a remarkable achievement as to where we are today. It's probably, as the Secretary General of the UN put it, it is the biggest success of multilateralism. He actually said that to the elimination of lead in fuels. And I think also the work on paints, which was ongoing for some time and needs to continue, has been incredible in the journey in terms of really focusing on trying to get rid of this problem. So that was the first phase. The second phase, to me, was the Georgia shock. And I'm going to put that right up there. It was a shock, because what happened in Georgia was that we were seeing certain issues, and the government of Georgia was hearing, for example, of the New York City Department of Health as well, that you've got lead in spices, you've got a problem with lead, and there was that story going on for some time. We worked with the government of Georgia at the time to integrate blood lead levels, testing of blood lead levels in the national survey. And we learned that 41% children were poisoned, had elevated levels of lead in their blood. This is not 5%, this is not 7%, this is not a hotspot problem. This is a serious issue. So that changed everything for UNICEF from how seriously we take this, because we thought this problem was addressed with the fuels, with the paints, and that changed that for us. And I think then with the great partnership we had with IHME, which I think was the third phase, with Pure Earth, to publish the Toxic Truth Report, which actually revealed that statistic that we are still continuing to face. 1 in 3 children, mostly living in low-middle-income countries, have elevated levels of lead in their blood. So that was a turning point. I think there is a lesser turning point I feel we talk about from that report that was also equally important, that the sources of this lead poisoning are diverse. They are not only paints, they are not only what legacy lead contamination you may have as a result of fuels. It is a range of consumer products we're looking at. It is a range of industrial applications we're looking at, but primarily batteries. And I think that changed again that, yes, the global source reduction strategies is important, but equally important are local data-driven approaches that are focused on solving the problem. That this is not only something we can deal with at a multilateral level through global environmental sort of governance. Countries have to take leadership and move this forward. And I think those were sort of important turning points to us. The report itself got a lot of media coverage at the time. It's reached some 850 media outlets, online, print. It got some attention, but not enough, because we were struggling with COVID. Look at the timing of it. We're talking about July 2020 when we are releasing this report. So despite that, we had a lot of sort of reruns because thanks to IHME numbers, we had these numbers available by country, and country media were picking it up, putting it out. And I think that was getting that attention, but not enough, not the outrage we hoped for as much as we would have wanted. Now, this growing global awareness is when the CGD working group actually came in, and that is, I think, a very important phase that we started to pull together experts in this area, organizations working in this area, and how to solve this problem. And I think that was very important. And the CGD working group came up with this goal of ending childhood lead poisoning by 2040. And that was a very important sort of a global goal that we landed with. And I think that's what we carried out to the Partnership for Lead-Free Future. As you can see, it's right there, ending childhood lead poisoning with 2040 as the goal. And that we launched that alongside the UN General Assembly last year. Now, here I must acknowledge the significant power that USAID brought to this issue. I think that was completely a game changer about how, at the leadership at USAID level, this was taken on, and we had the administrator herself driving this agenda across different forums. So as you can see, the goal of the PLF remains ending childhood-led poisoning. It is focused on empowering national action. So those are important to us because really you can see the journey and why that's important. Brokering solutions, so you see why this conference is so important. Raising awareness, harnessing the power of partnerships to solve this global crisis. So we've heard about 30 governments that are part of the PLF, and we have, of course, partners, and we're doing mapping as to which country, which partner is working in which country. That's very important. But right now, what we can see, even with the partners that have provided data, and we have a lot more to pull together, 55 countries. We have international partners at this point of time supporting 55 countries. And I think that's important to remember that this is something we've just started, and look where we are already. But of course, we have challenges. And even when we were launching this Partnership for Lead-Free Future, we knew that we are struggling with a range of challenges, conflicts being number one for children, climate change, number two, debt crisis, which is straining the resources. But we still went ahead. We said, this is a problem that we can do something about. We went ahead and we solved it. We launched it. We haven't solved it. We've got to work together to solve it. But I think the second related challenge, which was a big shock, and I think we're all sort of feeling it, reeling with it, was the withdrawal of USAID support. And I think it's really, really been a setback to the Partnership for Lead-Free Future, to the lead work at the global and at country level. But we are incredibly grateful to Open Philanthropy for having to step up and sort of help support the establishment of the Partnership for Lead-Free Future Secretariat, but also the work Open Philanthropy is really doing in terms of helping sort of strategically address this issue across a range of partners in terms of bringing their best to this agenda. We will soon have a full team working on board, but I have to still say that we will miss USAID because USAID was extremely important. And often we talk more about the aid part and the resources part, but I cannot stress enough how important that voice was around that table. And I'm talking about country level and what we're feeling and what it takes to actually drive agenda, because UN much values a bilateral partner championing the issue together with. So that is the challenge that UNEP, UNICEF, and WHO will continue to face. So where we go from here, and I think it is where I think this collective of partners that are here, I think is really, really important in terms of driving this agenda. And I think the one thing that keeps us together here is that we know amongst all the problems, which is I think why we launched the PLF as well, amongst all the problems, we think this is definitely a solving problem. We can do this. And I think that is something that brings us together. And I think we have to drive that. The second thing it helps us we know about is that the return on investment is huge. And it's not always well understood, but we know what it means for health. We know what it means for education. We know what it means for a country's economic growth. So PLF would be harnessing the power of this collective, working with CGD. I think that is how we would see. This is an area of significant growth and learning. And this conference, of course, is an excellent sort of an agenda towards that. I looked at, of course, the agenda, and I've said it, I think, to you, Rachel, a few times. What an excellent agenda that you've put together. I think a lot of them are important in terms of solving the problem, whether we're talking about the source attribution issues, we're talking about solutions to the battery recycling problem, we're looking at surveillance, we're looking at supply chains. So I'm really looking forward to listening to all of this and soaking it all in and thinking about what this means for us. And at the same time, we invite all of the partners that are committed to this movement to join the PLF. Sign up to the Partnership for Lead-Free Future by just visiting our website, which is leadfreefuture.org, as simple as that. And thank you for the shared commitment we have for ending childhood lead poisoning by 2040.
Thank you, Abhya.
Very nice.
And one thing I do want to emphasize while I still have the floor is to echo your point about USAID. I know we have some former USAID colleagues in the room, and I understand, it's obviously been a very challenging time, but We are so grateful for everything you did to advance this agenda, and the impact of that is durable, and it really matters. Okay, so next up, Tayo. So you're coming from the World Bank. The World Bank works on every issue relevant to development. It has quite a broad mandate and remit, of course. Why did the World Bank decide to make this a priority, given everything else it has on its plate? And then, as you're formulating your response and thinking about the role you can play in this space, do you see research gaps that are slowing you down, where you say, if only we knew this, then we would know more effectively how to engage here?
Well, I'll start by thanking you for having us around this table. We are not primarily a research institution, but we are a development institution, and our remit is, to end poverty on a livable planet, and lead pollution speaks to all of that. And I think the convening power you have here, I can see it, because so many of the things I want to speak about are things I've done over the past couple of years with many people seated here. So it's really great to be here and to be speaking about this. So dealing with lead is not brand new to the bank, just like Abid said, looking at our system. The oldest project I saw that named lead as an issue was from 1995. And that's probably when things were digitized. Not that that's the oldest project, because it's an enduring issue around the world, particularly for children. But more recently, we did some research around 2023 that you mentioned earlier on as well, that identified that number of 5.5 million CVD-related deaths. And that was, a light bulb moment across the institution. Like, this is something that's not just impacting even mortality, but actually productivity. So that's when we kind of refocused, and it was very timely alongside the formation of the PLF, which we also joined as a founding member. And it helped to kind of coalesce, what we were thinking about. How do we deal with this? And we sat down to think about a strategy for us as an institution. And it hinges on three main things: testing, prevention, and remediation or cleanup. Testing of people, the environment, but also products, right? Because we know it's everywhere. Prevention, that's, I guess, something that the World Bank is kind of uniquely placed to support and influence. That's really working with governments to figure out policy measures in health, water, waste management, energy, all those interconnected sectors. How do we begin to prevent that kind of exposure? And then cleanup. We're focusing mainly on drinking water system remediation and also consumer products. So that's how we formulate our approach, but we're doing other things. We're thinking about advocacy and raising the profile of the issue. We worked on a G20 expert session last year where we spoke about lead as a global issue and brought thought leaders together. We've also helped a policy session in Peru. So there are things we're doing all over the globe in various projects. We've actually started some remedial cleanup projects in drinking water in South Asia. It's about $500 million worth of investment in Pakistan and Bangladesh, just looking at changing the water systems, making sure they have lead-free fittings, monitoring, and of course some of the kind of support we bring with technical assistance, giving an understanding of how to prevent these issues in a broader sense. And then something we also do is knowledge, right? One of my colleagues will be sharing later on in the agenda tomorrow about some of the analytics we've got looking at lead exposure in paint in Indonesia. And we'll also be launching next month. It would have been lovely to have done it earlier, as you know, as we discussed. But we'll be launching A World Without Lead, paving the path to a healthy and productive future. So that builds on that earlier research that we did and looks at methods of preventing exposure. It looks at some of the cost-benefit ratios of various sources as well. And we're also looking at linking this, really strongly to the fact that our global agenda has been focused recently on jobs, and where we're speaking about IQ deficits and productivity, and also, just generally having a workforce that can meet the challenges of the future. The report describes some of that thinking, and we'll be launching that soon. So for what am I hoping to gain from being here? Obviously, hearing so much of this. We work alongside our partner governments, so we're looking for solutions that they can adapt. There's a bit of a gap, right, between the fact that we know the lead is there and how much is there. How do we fix those issues? So solutions for that are maybe not huge or widely available, but also scalable. That I think would be the one most important thing I'd like to take home from here, and to share with our counterparts. So I'm really looking forward to this agenda.
Terrific. Well, I hope we can deliver on that. In the meantime, this room now is aware that you will have summer beach reading upcoming from the report. So I, for one, am quite looking forward to it. So I know you have slides. Caroline, can you grab the clicker I left on the on the podium delinquently? But Indu, we'll get those loaded and we'll get you your clicker.
Thank you.
Can you tell us a bit about India's growing response to lead exposure? So you have a key role as chair of the India Working Group. A lot of things are happening, and I hear from you that things are really happening now. So we'd love to hear what's happening, how you came into this space, how research convinced you, and how you think it convinced other policymakers that this is something to take seriously, and how you see the role of research going forward as part of India's response.
Well, thank you very much, Rachel, and thank you. And I want to add my bit to congratulate you on taking this leadership and making a difference. And so of course, and thank you for inviting me. And so India, of course, is home to 1/5 of the population, global population. And if you look at number of children who have high blood lead levels, probably 40% of children live in India. So obviously, whatever happens in India has an impact on whatever is happening globally. And let me start with the conclusion. And India is moving after a long time. And I think thanks to a lot of partners here who are sitting here, and financing coming from Openfield and others, and a lot of research coming out of many places, including CGD, I can see the movement. People say that India is like elephant and it takes time to start moving, but when it moves, it has a momentum. And I'm hoping that that momentum will continue. But we see that those green shoots, both in academia, but also in the government. And so far, what has happened is the vicious cycle, because there's lack of data. Because there's a lack of data, there's no program, no capacity for generating those data. And since there's no data, there's no political commitment. And since there's no political commitment, there's no money, and then no data. So that vicious cycle has been there, and which is now changing. And the research is coming out from various fields, including internationally, globally, UNICEF, Pure Earth, and others, has shown three things. One, that there is a problem. There is lead levels are very high, and in India, it has impact on children. It has impact on economy. So there is a problem. Second, there is also data where what the cause of problems are, and it's also clear that it's very complex. And India, a place like India, where there's a huge diversity, and there's also diversity of sources and exposure of lead, and that also is coming out, that what the causes are. And lastly, and most importantly, there is an information and research coming out about what works and how it can be addressed. And we have research not only coming from India, but from across the world, Bangladesh and other places, Georgia, that how we can address this problem. This problem is addressable. So all that actually is having an impact on the way government is working. So here, what we're seeing is that National Center for Disease Controls, and CDC, which is based in Delhi, is a subordinate office of Ministry of Health, has taken over this role of providing leadership, and they want to provide leadership on lead poisoning under the broader umbrella of all heavy metals. And so they are anchoring a national biomonitoring program for chemical toxins, and they are building that up. We are also seeing that so far in India, there is no benchmark for what is the standards for BLL. And so DGHS, Director General of Health Services, is now establishing a workforce where they'll be establishing these benchmarks and reference levels for lead and other heavy metals. We are also seeing that there is a more systematic approach for surveillance, and Innovation Hub is being established where most cost-effective ways of assessing lead levels could be established. And large number of studies and think tanks are getting involved in terms of research on lead and the 3 areas that I mentioned earlier. We are seeing a lot of work on that. And finally, what we're seeing is that new partners are coming in. Of course, traditionally, Pure Earth, Vital Strategies have been involved in this. But most recently, we had World Bank working in UP, which of course is a game changer because World Bank comes, people take note of that, and the work in UP is progressing well. UP is the largest state in the country with a population of more than 250 million. So that's very impactful. But also Asian Development Bank, last week on 29th, Scott Morris organized a big meeting in ADB, inviting all heads of departments of Asian Development Bank, and he invited me to set the stage. And so there was a discussion on strategy for ADB, how ADB should be involved. And I'm very happy to say that all the heads of departments were extremely convinced about the need for doing this. And many of them actually have started the work in Mongolia, China, and they're coming up with a strategy on lead, which will go to the board later this year, and some resources which they're committing. So I think a lot of new players, apart from the traditional players, are joining in, which is a good news. And I was saying that India is a big country, and as you can see that in terms of states, India lives, of course, in several countries, from Kerala to Bihar, Kerala being very close to upper middle income country in terms of health systems, and Bihar being close to most developing country in terms of health system. But in most of them, I think some or other the partners are working. And I'm seeing the trend that maybe in next couple of years, probably all the states would have one or other partner supporting lead work, including my own organization, Pale India Foundation, under which we have created a vertical called ILEAP, India Lead Elimination Action Partnership, which is supporting work in 3 or 4 states right now. So just to round up what we are doing in ILEAP, we have 4 types of activities. And the major activity that I do is advocacy and communication and with the policymakers, both at state level, but also at national level. And I've been trying to convince a series of health secretaries and health ministers at the national level, but at many states about the problem and what they should be doing. And some of that work actually moves, some of it doesn't. Like elephant, it takes time, but I think the one starts, it's very difficult to stop. Then we also started working in several states. These are Meghalaya, Mizoram, Assam, Odisha, Rajasthan. We are working with them. And one study that we are doing, which we're very excited about, is 7 APEX medical and health training institutions, what we call AIMS, All India Institute of Medical Sciences, in 7 states have come together and they're doing a study of blood lead levels in those states. And hopefully when the study is complete, this will be the biggest study of its kind in the country, providing very credible data for policy making that we are supporting together with the Open Philanthropy. We are also developing SOPs, and we are creating a playbook for 11 ministries in terms of what they should be doing for lead. And hopefully when this is done, together with hopefully our partners like UNICEF and WHO, we would be asking ministries to adopt them and use them for their work. And finally, we are doing a lot of work on capacity building. As I mentioned, that NCDC is the apex organization leading the work on lead. We have embedded people in NCDC, but we are also providing, hopefully, a technical support unit so that they have the capacity and resources to take this forward. We are also working with the many ministries and other states in terms of strengthening their capacity for taking this work forward. With that, I'll stop, and thank you again, Rachel, for getting me here.
Yeah. Thank you. No, it's stunning to see what's happening in India and what you've been able to kick off. So congratulations. Okay, so we're going to have a brief moderated discussion. We'll then also have an audience Q&A. So if you have questions, start queuing them up and thinking about them so you're ready to go in a couple minutes. But I'll start with a couple for our panelists. So this is primarily for Abhid and Tayo, I would say. But we talked about the USAID withdrawal. That obviously has implications for lead because they were so active and helpful in advancing this issue. But there's also a broader context now of aid crisis, right? Severe aid cuts, a lot of organizations in very problematic fiscal situations, a lot of countries scrambling to figure out how to buy medicines and basic supplies, stand up nutrition programs. Debt distress is a very significant issue. So there's a broader context we're operating in. How has that change in the tides impacted the kind of conversations you're having with countries, how you make the case, how you think about positioning it compared to all these other issues which might feel and might genuinely be more urgent, and life or death questions? I don't think it's an easy question to answer, but it's one I wrestle with, so I would love to hear your perspectives on it.
I was going first.
It goes to me first. Well, I'm not going to sidestep, but I will start with, I think, what I find encouraging. My first lead project, and I'm aging myself here, was in 2002, a health impact assessment for a lead mine in Southern Africa. And in 2004, the World Bank completed a pilot for the remediation of that site. I wasn't working at the World Bank all that time ago, but that's a cycle of continuous work, right? Irrespective of global trends and changes. But I will say that for us as an institution, the focus on jobs that we have hasn't changed the way we look at lead, because there's a nice direct line between productivity, competitiveness, and jobs. So, our desire to work on this hasn't changed. On the issue of our individual counterparts, there are so many things that influence those discussions, and it's a very country-by-country specific kind of conversation. But where this is an issue, it remains an issue. So for me, I would encourage everyone here that as long as the issue remains, I think the will certainly in the World Bank to work on this is very much still there. And as long as that part is there, we're there to help as well.
Yeah, so of course this is a complicated question. I mean, I wonder if this is the right analogy, but I think about, we had COVID-19 outbreak, and then we did a lockdown, and we don't know what the implications are, and we're still learning what the implications are. It's a bit like that, if I had to put it like this. I mean, there has been, now I think the big shift that's happened over the last couple of years on lead, just going back to the previous conversation, has been that it's no longer an environment issue only. It is a health issue. And you're having ministries of health take leadership. Now we are in a situation where we have had the biggest partner on global health, USAID, decide that, or the US government decide that there is a change in policy or change in priority. That is playing out at the moment for ministries of health for the countries that received a lot of support. If you have to think about it from the context of environmental health, lead is an environmental health issue. So where does environmental health fall within the prioritization of ministries of health? And that's a fundamental challenge, right? That is our starting point. Now you have this contraction that you're seeing around health. You're having a withdrawal of key services that were supported with US funding and funding from other donors that are also questioning it. So when ministries of health, and of course we know about the debt stress, so when ministries of health get a finite amount and that starts to shrink, what will be their focus in their priority of priorities? And that's how you got to think about what will that mean for disease outbreaks, what would that mean for immunization services, for maternal newborn child health, basic services, the essentials that they deliver. Because when you talk about environmental health, it is, yes, the ministries of health is an important starting point, but the solutions are not within ministries of health. So then you go into this collaboration space. So that's the complexity I think that we are dealing with at this point of time. And I think for the moment, it's really important to be very thoughtful about which countries we are going to and pushing for what in this current climate. So I think that's the one pitch I would say. I think it's really important thinking about how to invest in a context that we are facing at this point of time over the next 1 to 2 years, particularly.
Yeah, please.
From the field, from the country's level, I think withdrawal of USAID has been impact has been very tangible, visible, and negative. And I can tell you both in terms of funding, but also in terms of advocacy. In India, I've seen that Pure Earth, Vital Strategies, and others have been involved, but the impact on policy, government taking the note, was not there till Atul Gawande came to India and had a meeting at the highest level and had meetings with the large number of stakeholders. So withdrawal of USAID, of course, has had some setback on advocacy and the momentum that was building in the policy space. But also at the field level, although the money that USAID gives to Government of India is a very small proportion of their budget, but that was the only money apart from other NGOs which was coming officially for supporting lead poisoning. And all those projects have stopped. Jharkhand, which has had a very good momentum going, the program has completely stopped. A couple of other research projects which were all ready to go, they've stopped. So I think there's a question of the credibility of donors and the international movement as well, that we need to continue those projects and both optional projects but also research projects. And here I would have a plea to the donors that I think we should at least pick up all those projects which are half done and take them to their logical conclusion.
Yeah, I mean, that is something we see in research supported by USAID and the US government across the board, and it's very frustrating. Someone who believes in, if you believe in science and you just care about the people who are sometimes part of these clinical trials, it's really one of the worst parts of it. But I think that's an important plea for funders. So, I mean, I think that's a little bit of a negative context, but I do think we have a lot of positive momentum and things too. And, much of what we want to do in lead is cheap for countries. It's a regulatory change. It's something you can accomplish without stressing your budget necessarily. Absolutely. So I think that's quite a positive spin for how we can engage countries even in a time of austerity. But I guess one point on this, which is sort of around how do you engage policymakers on sort of research-based advocacy. And I guess the tone with which you come to people, what country at what point is all tied into this. We're kind of a diverse audience in this room, but this is primarily a research conference. And there's a lot of people here who have researchers who will hope their research ultimately is influential to a policymaker down the line. Do you have ideas for all of us collectively about, you've been sitting on the other side of that table, I think, both sides, both bringing research to people and hoping to convince them, and yourself being convinced by research that's brought to you. Do you have thoughts and ideas about what's most effective, potentially, even in a challenging environment? How should we be thinking about how we package, present, share, disseminate research to have it have the most policy impact as possible?
All right. You start with me? Okay. I think what you put together is fantastic. I start with that. I mean, all of that is very, very relevant. I mean, of course, they can speak to different parts of it. But, you know, when we approach, of course, when we start to work with countries as UNICEF, I think the issue is how do you get scale? And on scale, the issue is if you've got half the kids poisoned in a country, how do you bring those levels down by another less than 20%? So I would challenge that side of things a little bit. And that has got things to do with the sources we are focusing on from a research standpoint, the interventions, including market incentives or regulatory enforcement sort of solutions that are needed to actually drive that kind of a reduction. So to me, the biggest, and I think the Georgia example is a very important example because we are seeing that recent evidence that blood lead levels have declined by about 59%, in at least 2 regions that we worked on with our partners on that. And I think that's important because that's the point of proof at the end of the day. So US has taken 30, 50 years, Paul will correct me on this one, but it's taken a long time to actually reduce blood lead levels, but we got great results with some of the source-based interventions, but the sources were prioritized, of course, based on local this thing. So I think just going back to that issue about now we're looking at Bhutan very focused in UNICEF to say, how are you going to bring the blood lead levels down for the 51% kids in Bhutan who are poisoned? We never expected that to happen, but the survey is telling us we know a few sources. So how do we drive that? So I think the research focus, what can deliver the maximum impact, I think I would push for that. I would push for speed. I would push for sustainability. Those are the 3 things. So we have said it's a solvable problem, and it needs to be solved once and for all, and we need points of proof to help get there.
Makes a lot of sense.
Yeah, I think there are 2 key questions, I guess, that frame our discussions as well. And they're quite similar to yours. It's, you know, where is the lead? How much of it is there? And what's the cheapest way and easiest way to get rid of it? So along that continuum, you have the need for, I think, very cost-effective sampling. It's not expensive, but it adds up. You know, we know from UP, it's not a huge study, but it really does add up, particularly in these contexts of very densely populated areas. So that would be, I think, key to identifying or helping policymakers decide where to put those very specific interventions. And then, you know, there's a lot out there about the effects of lead, how to remove it from sources like drinking water, like consumer products. That's not so difficult, right? That's more an issue of will, because having lead in toys is not needed. It's very much political will. So I'd say every time we put out a paper showing how much there is in toys or whatever, that is a form of advocacy. So let's keep doing that, keep putting the message out there that this is there, it doesn't need to be there, let's get rid of it. And then hopefully legislative change will also follow. And then lastly, I don't know personally, in my experience, many really effective ways of getting rid of lead in people already exposed. Not that there aren't cures, there are cures, right? But it's difficult, it takes time, it involves a lot of hospitalization or monitoring, you know. I'd love to see innovation in that space. There might not be a magic pill, but we don't know till we look.
There might be. There are some people in this audience who prefer to have one. So.
You know, I've spoken to maybe about 50 policymakers on this, and always our discussion starts with the strong denial, then sense of shock, and then more questions about what can we do about it. So first of all, I think not everyone knows what the extent of problem is. There is a need for sharing that kind of information. But then question comes, so what? There's high blood lead levels. And so In India, we have so many other problems. Pollution is a big problem, and then malnutrition is a problem. Then linking lead levels and with very convincing evidence that it is linked to some of the development indicators, outcomes that we care about. For example, in India, we are very concerned about malnutrition. And if you can show very clearly that lead levels are linked very closely to malnutrition and anemia, that moves the needle. But also, India is very keen, and they think that we believe that demographic dividend, like we have a working age population which is going to be leading us to become a developed country in about 25 years. So if we can show that, unless we address the issue of lead poisoning, probably we are not going to be using our potential of our children, is a very powerful message. So linking those aspirations of the country with lead problems through very convincing and evidence-based research is important. And lastly, they say that if I have to go to my boss, minister, chief minister, prime minister, that this is a problem, I should also know the solution. And you'll tell me what the causes are, what the sources are, why this is happening, because is it happening because of air pollution, or is it happening because of water? And so that is very important for them, because they can't actually approach the problem unless they also know the solution. I think that is something we need to help them with.
And a question for you, about the India context specifically. So it's one thing to kind of go to a policymaker and talk to them in policy terms. It seems like another big potential audience here is the broader public, right? And how they think about it. And I think we saw in the United States with the Flint, Michigan crisis that actually it was public pressure more than policymakers being convinced that led to people taking it more seriously. What do you see in India? Is this an issue that resonates with the public? Did they say, actually, who cares because we have more pressing concerns? How does that land in public opinion?
Well, I wouldn't say that that can't be done in India, because maybe the pockets where we can mobilize people and they can put pressure on the system to perform, especially if we know exactly what the problem is. If we identify some areas where water is an issue, I'm sure communities will put a lot of pressure. And we have very strong civil society as well. So I think that can be done. But, those will be very micro experiments. And India is 1.4 billion people. So I think the top-down approach probably will be most effective, at least in the first go, where we have very strong regulations on paper and implementing them is the issue. I think that's where probably one should focus on. And sooner or later, when this happens, the pressure from public will come for sure. There are some areas where, especially all the communities which are close to mines and the power stations and some other industrial areas, including sites for ULAB recycling. So their community will be keen to take it up.
Great. All right. Well, I'm going to ask for if anyone in the audience has a question, and hopefully we can share some mics around. Everyone's try today? If no one volunteers, I have to just keep asking questions, so you'll get more of mine. All right, we have one over here.
2:15?
2:30.
Thank you. Hi, I'm Elena Walls, former USAID. So I was just wondering, as a data person, I always say, show me the data, right? And if we don't have access to data, how can we organize collective action? So my question for the panel, as myself being a parent and trying to figure out how do I test, right? The testing issue, I think, is a really big one, especially like spices, food. Lead is invisible. How do we, mobilize communities around this question when you cannot see it and get data very easily, right? So what do you guys think about that data issue?
Do any of you want to take this?
Well, if you don't know, ignorance is bliss. So everything is hunky-dory, because, for example, if people don't know that turmeric that they're using has high lead levels, there's no problem. And also, the people who are mixing, say, lead chromate and turmeric, they probably don't know that it's harmful. And that's why they're doing it, because they're not doing it just as a vicious people who are trying to make money off other people's misery, but they're doing it because they think it's an innocuous item. So I think data, of course, has to be first thing, because in India, like I think Rachel mentioned, that globally, the sources are varied, and in different communities, the problem why they have high lead levels in their blood is because of different sources. So unless we know that kind of linkage and where this is coming from through convincing data, I think approaching it will be difficult. Communicating it will be difficult, because communicating to people that there are so many sources where you can get lead is impossible, because for them also to act on that will be not feasible. Therefore, this kind of data, micro data, and also data about indeed they have high blood lead levels is important for communities to take action, but also the governments to take action on, right?
No, I think that's a great question, and thank you for asking that. And I think that's typically the voice you would hear from a parent. And you think about countries like Georgia, where we actually came up with that 41%, and what that meant to the people that were reading the news, and so 41% means it could be my child. It's most likely my child, right? So how do I know? And what that pushed was the state health program, and I think some of these things we're so focused on problem solving that we're not considering always the human element here. The government had to respond, and that is what it means. You have to go back. So one of the key points in the things that we, as a sort of a design standpoint, are sort of focusing on in UNICEF and have happening in a massive way in Bangladesh right now, because we're testing 9,000 kids and 4,500 pregnant women, is to go back to those families and to go back and tell them, like, this is what we found, and this is what we know, what you can do at this point of time. We are continuing to investigate that. And then the next thing will be, there'll be a demand that, we need this, we need to know, I need to know about my child. And I think that's where we should not underestimate that demand for a proper surveillance system. And Georgia has been in that journey of having a nationwide surveillance system, but I think we need that in many of these high-burden countries, and particularly that moment when we have solved that 50% to 20% I was mentioning before, but after that 20%, you need surveillance. And we need to have it in our New York City Department of Health, I think, as well as Dan, we've talked about these issues, that it needs to be there in some way or the other. Even if it's like a few kids, at least we follow up through. We're seeing the same demand in Bhutan at the moment. So very valid and very, very real.
And I think on top of that kind of monitoring response, we also need these kind of global responses, right? We didn't need to check lead levels in every country to know that we needed to come together as with a global approach to reducing or eliminating lead from petrol. So what we're doing here is a very key part of that puzzle.
Absolutely.
I am Denny Dobbin, an occupational hygienist and on the board for the Terrographics International Foundation. And in my experience over the last 50 years in the workplace, I've seen, and in Pakistan, Bangladesh, and other countries, as well as here, I've seen a lot of child labor. And I think that's a place to consider about in terms of bringing supporting families, productivity, if you want to, I'd fit part of that, at least into productivity, which I think is an incredibly important part of that. And the other thing is take-home toxics. The idea is you come home and dusty clothes, muddy shoes, children eating dirt in the area, airborne lead exposures. I'd urge you to consider that as part of your thing. And maybe you're already doing that, but maybe I could get some comments along those lines. Thank you.
Maybe Avit as our UNICEF children's representative.
Sure. I mean, I could start and then
Sorry.
it's so much related to the work of the bank as well. I think, thank you for touching upon that point. I think child labor is a major issue, particularly, in some of the countries we're talking about. And it's not only lead. There's like layers of this problem. We, in fact, recently even issued a report in UNICEF on plastics and the impact on children. Sort of the top of this pyramid are these children working in toxic sites. Are those working in landfills? Are those that are engaged in hazardous work, including agriculture at times when you use pesticides? So we are deeply concerned about that. The socioeconomic drivers are, of course, complex, and that's where we need sort of more concerted sort of strategies beyond the legislation side of things, which is, of course, prohibiting child labor, as we know, but the reality is different. So that's where we got to work around things, and some of these things we're going to be thinking about the strategies to address more comprehensively. But I wanted to come to that second point of your question, the risk communication side, and I think that is also a research question, if you like. In terms of understanding the behavioral insights. One of the first things we're doing, we did that in Georgia, it's happening in Bhutan right now. What are we going to say to the families whose children are poisoned? It comes back to wash your hands, take home exposures, watching out for ABC things that are likely sources. Those things are extremely important. But I think it's what we have to also understand is how, going back to the point that was made as to how families are understanding lead poisoning, and are they taking those actions, and what are the behavioral insights around that?
So we have a whole risk standard around child labor or labor that has an element on child labor, and the fact that in so many different sectors, you have children being exposed just because they're helping their families.
Yeah.
That's how it's seen. It's not child labor to them. It is a child just helping the family. A litter picker, for instance, or someone harvesting cocoa, for instance. These are people just helping their families. So the idea is not necessarily to say no, because it's also like a developmental stage, right? Where you help out in the family shop at the weekend at a certain age, but to make sure that that process is not harmful and it's not leading to those kind of exposures. So that was the thinking behind having that in our embedded in our kind of risk management system. But also, the report we have actually shows very clearly a conceptual site model for ULAB recycling, for instance, for a worker, showing how, taking their clothes off at home releases dust into the home. And it's similar to so many other industries, as you quite rightly identified. It's not unique to this particular type of working. So we do have a conceptual site model there showing, it's a chart, and I'm not even sure how many linkages there are there actually to exposure within the home. So we identify that, we see that as a very critical element of reducing global lead exposure as well. So yeah, more to come.
All right. Oh, we got a few. Okay, in the back over there.
Thank you so much for kicking off this conference with such a great panel discussion. My name is Harriet Okach, and I am an associate professor at Thomas Jefferson University in Philadelphia, where I teach public health. So my question really stems from the fact that when we look at sources of lead, contextually they can be very different. And while we think about screening and problem solving and creating solutions, it's really important to know where the sources of lead are. But I find that as we're talking about research and writing grant proposals, identifying sources of lead or even the prevalence of lead is not important enough for funders to fund. And yet it is a critical baseline for us to have foundational information from which to act. So what would your recommendations be for researchers who are in this space trying to demonstrate the critical importance of the sources of lead and the prevalence? How do you market it, I guess, from a business perspective, so that it is appealing enough to get funded? Thank you.
Well, I have a thought on this, actually, and then I'll pass over to the panel. I think the key thing, right, is, as you say, it's kind of marketing and sales. But I don't think it's just that, because it's also how you're framing it for yourself, right? If you're saying we're producing this research and it will go in a journal And some people might find it in the journal, but otherwise it will just sort of be a standalone piece of research that maybe will eventually get pulled into a meta-analysis or something. That's one thing. And I think for funders, they're going to say, well, if it's not incredibly novel, then that's not that interesting. But if, as is the case with a lot of our colleagues on the panel, you say, well, actually, we have a partnership with the government of Bhutan. And they've let us know that they're quite interested in hearing about this topic, and that if we generate data, they'll be interested in acting on it. And they want to hear that. So you have a partner and a client almost for it, where your pipeline from that evidence just being generated into it being received and taken up and used in some way becomes clearer. And then I think that becomes a much more compelling pitch for a funder, especially an impact-oriented funder, right? Where it's not just funding the research, it's funding a partnership that might lead somewhere very tangible. I don't know if you have additional thoughts on this.
Well, I'll talk a little bit about Bhutan as well. I think one of the things we have been learning from how we've been doing it as UNICEF, tackling about these issues, is sort of bringing the blood monitoring side with the environmental testing and trying to do that together as much as possible, either simultaneously or right after that. And I think, unlike the Georgia survey, which did not list the sources and was an investigation that followed for quite some time, actually after that, even before actually we knew about the source, actually, in Bhutan, that was done simultaneously. So you had the first order ones, like one of the, going back to local things, I mean, what the Bhutan survey shows is that GenLab, which is supposed to be a blessing that the lamas give, a mixture of herbs, had very, very high levels of lead in that, in a big part of the sample. So now that changes the way the government is looking at it. So we need that solution. And so for UNICEF, we've decided we're not doing blood monitoring because you put yourself in a problem, telling the government, you've got a problem, but we don't know where it's coming from. You got to work with the government to help discover that problem at the same time. So that would be a policy, that's going to be a political problem if we're raising problems and not talking about solutions.
That's absolutely true. No one wants to discover a problem that they have no idea how to solve or where it's coming from. Yeah. So making that connection and doing the analysis together is kind of essential to get a policymaker's attention. But also, I think risk communication is key. Do they care? They do care that there's blood lead or lead in this, but they care perhaps more about the cost to their health system. So linking it to an issue that whatever the policymaker is representing is a very good way to communicate the need for your information.
All right, one final question in the back over there.
Hello, everyone. Thank you so much for such a great discussion. I'm Amrita Kundu. I'm an assistant professor in the business school at Georgetown University. So I worked at the World Bank previously. So I kind of come from that policy perspective, but have now the business hat on, and I look at business operations. And I think one thing that I struggle as a researcher who wants to have applied research and have kind of impact of my research outside of academia is building that partnerships with, let's say, governments or organizations where we can actually evaluate, what is the right solution, because these are such complex issues that as an academic, I don't have the insights into what the government is thinking, legislation is one thing, but actually implementing that and getting it to work in the way that you had anticipated with the legislation, I think that's extremely difficult. So I wonder if there is a way as your organizations kind of proceed further to identify solutions to actually kind of collaborate with people in this room to actually do impact evaluation or figure out what's the implementation of that legislation is going to look like. Thank you.
I mean, a good point. I don't know that I have any specific reactions to it, except that I agree.
Fully agree.
Yeah. I think maybe just one thing I would say to add and not to answer your question. To be clear, I think we're at the moment in UNICEF really thinking about how we apply some of the things we've done in the health sector to the environment sector and really how that happens and how we think about this. So one of the things we are focusing on in several countries at this point of time is when your system is not pushing, then you've got to do something to change that. And so one of the things we're focused on is who is supposed to act on this problem. So you come back to food and safety authorities, commissions, safety commissions. You come back to the trade and industry, and sort of supporting them to do the market assessments and act and enforce. So that's at least one of the things we're trying to change that. And that's sort of our learnings in the immunization world. I have to say, when you start to do mop-up campaigns and things like that, because you've got so many children with 0 dose, so what are you going to do? You're going to figure out those kinds of solutions. So that's something at the moment that we are piloting in a couple of countries, which is going to hopefully sort of get the people that are supposed to act on that, sort of enforce that. But the private sector role is the role of business is absolutely a big part of that problem, because you can flag, you've got a problem here, you've got a problem here, I'm going to issue a directive, I'm going to do all the enforcement sort of steps that are needed, but does that get the product out of the market? And that's where you've got to engage that industry side of things. So we're looking for solutions there. So again, join the PLF and help us find these solutions.
All right, so I'm going to wrap up with a couple of reflections of what I've heard and then a couple of announcements, and then we'll leave you to your coffee break. So a few messages that seem quite relevant to me and to keep in mind as we go through the rest of this event. So the first is that research and data are advocacy themselves. A finding is a point of advocacy that can be brought to different partners. And let's think, as we see these findings, how we can use them to make a difference in that way, who they can be brought to, and how they can be useful in that manner. The second is what matters at scale. There's a lot happening, but it's a very big problem that we have to tackle. And thinking about what matters here that can, not just for a few people, but for huge populations. Let's all be on the lookout for that and thinking about what the findings are and how they can apply as meaningfully as possible to the most number of people. And then I think one very clear message from all of you is don't come with a problem and no solution. Now, I think that's a little bit, oversimplified, because sometimes you need to generate the problem to find the solution. But I think the demand on the policy side for real solutions, loud and clear. So that's something to kind of challenge all of ourselves to be on the lookout for. So just logistically, I want to first thank our wonderful speakers for their contributions. We are going to have a coffee break outside. We will reconvene here at 2:45. Just quick requests. If you can check under your seats and see if there's any garbage and bring it out with you. We'll be here a while and it can get quite messy without some tidying. And if you are a speaker on the next panel, if you can just meet us outside these doors to get magged up before you enjoy your coffee break. All right, thank you everyone, and we'll see you at 2:45. right. Trying again? Okay, great. Now my mic is on. So for everyone who did not hear it the first time because my mic was off, welcome back to our first full research panel of the research conference. It is time to dig into the healthy red meat of research. So we are going to be starting with a panel on new evidence of the impacts of lead exposure. So we have a number of great panelists that we'll get to shortly. But in the immediate term, I want to introduce our moderator. I would normally say he needs no introduction because he's been here. He's been a very long time colleague and has been instrumental in helping set up the lead program. But I'd like to, I'll momentarily invite up Justin Sandifer. Justin Sandifer, as of quite recently, is now a senior program officer at Open Philanthropy, where he leads work on economic growth. However, prior to that, he was here at the Center for Global Development as a senior fellow for many, many years and helped us stand up all our work on lead exposure and lead our research agenda. So Justin, over to you, and then over to the rest of the panel. Thank you.
All right, good afternoon, everybody. Good to be back after 6 days away from CGD. I'm really excited about this panel. This is one of the things I was going to be sad to miss at CGD, but I'm glad to make it back. We are diving straight into technical research content. So enough of that policy stuff. We get into numbers and weeds now. We're going to do this in this is kind of a hybrid session. We're going to do it in 2 tranches. And the first tranche, we're going to talk about the global burden of disease attributable to lead exposure. So many of us, maybe some of you, at least I, kind of got first excited and interested in lead exposure just on the back of some of these big numbers about the number of children worldwide who are exposed, about the scale of the health toll, the death toll, and the health impacts that lead was having. And a lot of those numbers come from the Institute for Health Metrics and Evaluation at the University of Washington and the Global Burden of Disease program. So we're carving out kind of a mini session within a session here just to hear from the IHME team. And specifically, we have Sandra Spearman here from IHME, who's going to talk to us about the global burden of disease attributable to lead within this whole GBD portfolio. How does lead compare to all the other things that are killing us in the world? So Sandra, please, the floor is yours.
See. Oh, perfect. Okay. Do you mind if I grab a water real quick? Thank you so much. Thank you. So thanks for coming to my presentation. Today I'll be presenting on estimating the global burden of disease attributable to controller. Yeah. Is it in here? No.
It moved for you, but it'll come here.
All right, let's just do next slide for this time.
Okay, okay. Sounds good. So yeah, today I'll be presenting on estimating the global burden of disease due to lead exposure. My name is Sandra Spearman. And before we get started, I wanted to do a couple of introductions. Next slide, please. So I'm a researcher at the Institute of Health Metrics and Evaluation, or IHME. It is an independent research institute based out of the University of Washington in Seattle, University of Washington, based in Seattle, Washington. It governs the global burden of disease study, which is the single largest and most detailed scientific effort to quantify levels and trends in health. Over 12,000 researchers from over 160 countries and territories participate in the GBD study. It compares the magnitude of diseases, injuries, and risk factors across age groups, sexes, location, and years. And it's to help understand the leading causes of health loss. So our most recent publication is GBD 2021. And all the results I'll be sharing with you all today is from GBD 2023. So these are all preliminary results and have not been finalized. So you'll see a lot of do not cites across my figures. Next slide, please. So for GBD, we model lead exposure as blood lead exposure and bone lead exposure. Blood lead reflects acute exposure and predicts IQ loss in children. Bone lead exposure is chronic exposure and predicts cardiovascular disease within adults. So the figure I have on the right-hand side is showing global, both sex, all ages for the year 2023 DALYs, which is a disability adjusted life years, which is just the summation of years of life lost due to premature death and years, thank you, years of healthy life lost due to disability. So as you can see in this graph, bone lead is is driving total burden and associated with 70.58 million DALYs. In contrast, blood lead is associated with 2.21 million DALYs. So I'll be going over our modeling overview for GBD. So our goal is to get to population attributable fraction, and to do that we need three components. We need exposure level, relative risk, and the theoretical minimum risk level, or TMREL. Combining the population attributable fraction, or PAFS, along with the disease-specific burden, we will be able to combine those two to get attributable disease burden, which is the final result for GBD. So for all of our methodology, it will be very quick and brief. So for exposure modeling, we first have, which will be in 3 steps. We first have input data, which is whole blood samples from literature and databases, national databases. And we produce blood lead exposure estimates using a spatial-temporal Gaussian process regression model. And the reason why we are doing this is because we need to have blood lead estimates for all location, years, age, sex that we do not have data for. So here we are seeing an STGPR model for South Korean females for 5 to 6-year-olds. The data points are the gray dots with the vertical lines being their confidence intervals. The purple line is the STGPR model. And the STGPR model is borrowing strength from covariates and strength from space and time, or information from space and time. Next, now that we have blood lead exposure data for all location, years, age, sex, we need to determine what is the IQ loss due to blood exposure, blood lead exposure. So we calculate a blood lead exposure distribution and convert that to the shift in IQ from an IQ of 100. And this conversion is using a scalar from literature. Here's a map showing the mean IQ shift due to blood lead exposure for 5 to 9-year-olds for the year 2023, with the IQ shift ranging from 0 to 6. So now that we have blood lead exposure, we have IQ shift due to blood lead exposure, we now need to get at bone lead exposure. So to do this, we calculate the cumulative blood lead exposure and convert that to bone lead exposure using a scalar from literature. Here, I show the mean bone lead exposure for 70 to 74-year-olds for the year 2023. And the mean bone lead exposure range I'm showing here is from 0 to 120 micrograms per gram. So now that I have exposure level for both blood lead exposure, IQ shift due to blood lead exposure, and bone lead exposure, we now need to get at the relative risk. And this is where we have methodological changes for GBD 2023. So we know from literature that bone lead exposure leads to high systolic blood pressure, and then that leads to cardiovascular disease, or CVD. Prior to GBD 2023, we were assuming that 100% of bone lead exposure led to SBP and then to CVD. But for GBD 2023, we wanted to understand what are the direct effects of bone lead to CVD without having to go through SBP. So to do this, we conducted an analysis on NHANES, which is the US National Health and Nutrition Examination Survey, which we conducted a survival analysis of the NHANES surveys from 1988 to 2023 to calculate hazard ratios. The NHANES surveys consisted of approximately 42,000 participants and consisted of 8,300 deaths. And of those deaths, 1,728 of them were due to CVD. We ran two models, a model that was adjusted for SBP, or high systolic blood pressure, and then a model that was unadjusted for SBP. Using those two models, we found that 95% of IHG was due to the direct effects of bone lead, and only 5% was due to the effects of bone lead through SBP. At this time, we were not able to look at all the other cardiovascular disease. So for GBD 2021, for all other CVD causes, we're assuming that 100% of it is bone lead through SBP. We also conducted a systematic review to look at the relationship between bone lead and ischemic heart disease. And using both the systematic review and decile results of our NHANES analysis, we ran a burden of proof model, which we are seeing here in this graph. The model did not include any covariates, and the exposure range was from 0 to 113.24 micrograms per gram for bone lead. The resulting mean relative risk values for that range was 1 to 1.8, and there was no evidence of publication bias. So what's great with the burden of proof model framework is that it outputs a star rating out to 5 stars. The resulting star rating for the burden of proof model is 3 stars. And you may not think like that's all that great if you compare it to a restaurant star rating. But within the GBD framework, 3-star ratings is fairly strong evidence showing the relationship between bone lead and CVD. And if to compare other risk outcome pairs that we model at GBD, other ones that are also 3 stars is particulate matter and tracheobronchus and lung cancer. And another RO pair that also has 3 stars is particulate matter pollution and lower respiratory infection. So now that we have our exposure levels, our relative risk, now we need to go over the theoretical minimum risk level, or TMREL. And I'll be going over this just very briefly. So the blood lead TMREL is 0.016 micrograms per deciliter, and this is based on pre-industrial revolution blood lead levels from literature. To determine the TMREL for bone lead exposure, we did the exact same conversion of blood lead to bone lead, but instead, we filled all the years for those cohorts with the blood lead TMREL. So we have a different TMREL across age group for bone lead exposure. So now that we have the exposure, the relative risk, and the TMREL, we can put all that together to get the population attributable fraction, and then use disease-specific burden to get our final result for GBD, which is the attributable disease burden. So this graph is showing the number of deaths for each risk factor at GBD for global both sex, all ages for the year 2023. And this is ranking them from highest to lowest. For bone-led, it was found that it was the 8th highest ranking risk factor for deaths, with 3.45 million deaths. For DALYs, which I mentioned before, disability adjusted life years, was the 11th highest ranking risk factor with 70.59 million DALYs. And I do want to reiterate that this is after our new changes in the relative risk, so our new methodological changes. And surprisingly, 75% of those DALYs, it was due to the direct effects of bone-led to IHD. And only 25% was the indirect effects, so that's the going from bone-led to SBP to all CVD. And in contrast, blood-led is only associated with 2.2 million DALYs and was the 55th ranking risk factor for DALYs. Now this is showing from the year 2000 to 2023. What are the differences between those years? So we know we have an increasing global population, so I wanted to take that out of the equation. So this is showing DALYs per 100,000 people. For bone-led between the years 2000 and 2023, we saw a 6% increase in DALYs. For deaths, we saw a 15% increase. And with blood-led between the year 2000 and 2023, we saw an 18% decrease in DALYs. So we also know that we have an aging population along with the increasing population. So here is age standardized, which makes it also more interesting. So this is age standardized for both sex for DALYs per 100,000 people. So for bone-led, there was actually a 25% decrease in DALYs and a 24% decrease in deaths. So why is this happening? Here's just a quick example. So on the left-hand side, I show an STGPR model, which is showing our blood-led exposure estimates for females for 2 to 4-year-olds in Brazil. And you can see that they have, on average in the 1980s, around just above 6 micrograms per deciliter for blood-led exposure. So now let's fast forward to 2023. That age group is now in the 40 to 44-year-olds age group. And we can see that the mean blood-led exposure ranges from 10 to 15 micrograms per gram in Brazil for that age and sex group for the year 2023. So what we're seeing here is a delayed effect. So you have blood-led exposure in your adolescence leading to high bone-led exposure later on in life. And I also wanted to point out that these blood-led exposures is prior to leaded gasoline being outphased in that country. So another example is in a country that we know has an aging population is in South Korea. So this is on the y-axis, deaths per 100,000 people. And we have years on the y-axis. And this is deaths due to just general lead exposure. And you can see it is increasing over time. I also included the bone lead exposure for South Korea females, all ages. And you can see as that increasing. For the blood lead graph, you can see this is only for 10 to 14-year-olds, but it's the same trend across all ages of it decreasing over time. So just to quickly summarize, global lead burden is large and higher than previously estimated because of this methodological change that we made. And we are having 3.45 million deaths in 2023. Generally, lead exposure are decreasing, but lead attributable burden is increasing, and this is being driven by adults with CVD, and it's largely due to population growth and an aging population. It reflects much higher historical exposure in their adolescence. And then continued exposure reductions will decrease burden for both adults and children, but there will be a delayed effect in that. So I wanted to leave everyone with some resources for GBD. These are all QR codes. So the first one I have is how to join our collaborator network. We love working with collaborators, especially with data collection, running systematic reviews, things of that nature. We have GBD data and tools. This is where you can find what data is in the GBD. And we have visualization tools to see all of our results, which actually the majority of the graphs I showed today was from those visualization tools, so you can go and recreate those yourselves. Then we have GBD trainings on how to run the visualization tools and a couple other trainings as well. Then we have data tools and practices, and that is showing you how we get our data, how do we store our data, and again, where to find that data. And then our most recent publication is GBD 2021, and our next publication will be GBD 2023, which will be published hopefully soon. So yeah, that was all. Thank you so much.
All right, my mic on? Yes. We've got about 10 minutes for questions for Sandra. I'm going to kick off, and then I'm going to turn out to all of you. So warm up your questions for Sandra. That excellent presentation. That was fascinating. I work in philanthropy now, and I work in a corner of philanthropy that takes the global burden of disease numbers like super, super seriously, right? And if you tell us more people are dying from lead exposure than from malaria, that's going to mean less money for malaria drugs, right? So I want to talk a bit about the uncertainty. You know, it was a beautiful presentation of the numbers, but for outsiders, it's often hard to penetrate GBD and understand what's fragile and what isn't. And since you know the inner workings, and I'm sure you've tried different parameters, like talk to us about, is it about the imputation of bone lead levels in specific geographies? Is it about that causal link from bone lead to CVD? Where do you see, can you talk about the magnitude of the uncertainty, the sources? Like, what worries you about this number?
Interesting. Well, I can say that with the uncertainty, we do provide, we do calculate, I should say, uncertainty for all of our estimates leading up. So from exposure to the relative risk to the TMREL, and then to our final estimates of attributable burden. So those uncertainty intervals do essentially have a effect on the final results. We do have, if the presentation could be put back up, I do have a map showing our data sources. But we do have fairly good coverage globally of all of our input data for blood lead as well. And speaking to, and I should also mention that compared to other risk factors at GBD, I would say lead is kind of like the middle ground of like data availability. So there are some risk factors that have more data than lead, such as like air pollution or wash. But there are other ones that have much less data, such as childhood bullying or radon. To your question of the relationship between bone lead to CVD and like our confidence in that as well, what's great with the burden proof model is it has that star rating, and we're able to compare how that fits into other risk factors. And it is fairly high compared to many other GBD risk outcome pairs. And for that as well, we did our own in-Haynes analysis, and we're fairly confident in those results with that like result alone. So yeah, I would say that we are fairly certain on the causal relationship between bone lead and CVD for direct effects. And the uncertainty question, that is something we certainly could do, is get more into the uncertainty and comparing that with other geographies.
Great. I thought that comparison of the confidence you have in lead vis-a-vis other causes was a super interesting comparison. There's hands shooting up, though. So let's do a round. So first Will here, and then here, and then I'll turn my head. First these three. Yeah.
Thanks so much, Will, with the World Bank. Yeah, I was curious about this question of statistical support in different geographies, because I know in some countries, the surveys that are being applied to the model are not nationally representative. Oftentimes, they're for like a specific geography or population, which may raise concerns that it's a sort of that there was a particular reason that population was surveyed. So I was wondering if you could talk a little bit about sort of how you account for this when you're extrapolating to the general population in these countries where there's maybe not a nationally representative survey that we're basing it on. Thanks.
Yeah, so,
Can I
of course.
pile them up? Or are you going to test your memory here? I'll try to help you if you forget. The woman in red, yeah.
So thank you for that great presentation. Sumi Mehta from Vital Strategies. I just had a question because there's a lot of people in this room who are also doing research within this space, and I'm wondering, when you're looking at the burden of proof, I understand that 3 stars is a very respectable number of stars, but I'm wondering what gaps do you see that would really also further strengthen the evidence and the burden of proof that you have, and where would those be, if you were to be able to prioritize that kind of research?
And one more, you have to keep track of. Gentleman in the suit here, yeah.
Hello, my name is Taddasa Amarra from Ethiopia, Executive Director of Pan Ethiopia. Thank you very much for the presentation. I have 2 questions. The first one is, did you by chance relate those results with exposures retrospectively? If in one country some sources are higher than the other, or specific sources. The other thing is, how did you exclude the confounding factors in order to come up to a conclusion to cardiovascular disease or others? Because it can be a contributing factor rather than, lead poisoning is dangerous. We know the result is real, but to come up with one sample directly to be linked with the other one, how could you use the exclusion criteria from other exposures or lifestyles? Thank you.
So you've got non-representative samples, how to get more stars. Then we had sources and confounding factors. So
okay.
You can deal with all of that.
Yeah, I was going to say. I'm so sorry. Can you repeat your first question?
It was just how you're accounting for maybe non-representative samples.
Oh, yes. So when we take in our input data, we take in whole blood data, and to be able to bring it into our GBD exposure modeling, it must be representative of the general population. So we do not take in data that is, say, it's a mining community that's specifically using or mining for lead. So we do try to exclude any studies or sources that explicitly aim for people with elevated blood lead levels. And did you have another question? I felt like you did. Okay.
How do we get more stars? Where do you see gaps?
Yes. So for that one, definitely just more studies between bone lead and CVD or IHD. It felt like when I was doing the systematic review that it was fairly limited. So I guess the answer really is just more studies looking at those direct effects, especially looking into, again, the general population between those direct effects, or larger sample sizes. Sometimes it would be a very small study. We will be releasing a paper with this whole new methodology, so you'll have a lot more details in our systematic review and our NHANES analysis. But unfortunately, the simple answer is we just need more studies comparing the two. And then what was the last
We had going back to retrospectively to sources underlying the exposure and how you dealt with other confounding factors.
Yeah. So when it comes to just exposure, we only take in whole blood lead samples, so we just want to know what's already in your body. When it comes to, I think you might be hinting more at the relative risk, where we have a lot more confounders. For that one, we did do adjustments for like BMI, smoking, age, and when we did our systematic review, we also included studies that adjusted for those kinds of confounders. We do, when we were doing the NHANES analysis, we did test a whole bunch of confounders. There was a whole long list of everything we could try and think of that was included in the NHANES analysis to try and adjust for those and seeing like what actually had an impact versus not. And again, we will be releasing that paper so you can read that in more detail. Yeah, please let me know if you have any additional questions on that.
Okay, I'm going to have to break my promise. I'll try to move to other parts of the room for the next presenters, but we're out of time with Sandra. That was a beautiful presentation. Thank you so much, Sandra, for that. Another round of applause. Okay, and this brings us to kind of part two of our stitched together session here. We've learned about kind of the scope of the burden of lead poisoning worldwide, and now we're going to turn to kind of the frontier of new research, presenting new evidence on causal impacts of lead on cognitive and health outcomes. So we have three separate papers, three different geographies, all trying to get at this question of causality with really kind of clever natural experiments to tease out those causal parameters. So our first is Emily Burkout, who is a research associate at Youth Impact. And she is going to present research that she's been doing in Indonesia. Emily, it's great to have, we got interested in lead here at CGD from a combination of the health and the education teams. And I'm always excited to see education researchers working on lead. So great to have you here. The floor is yours.
All right. Well, good afternoon, everyone, and thanks for having me here. My name is Emily Berkhout, and I'll present to you work with my co-authors from the Asian Development Bank and the Asian Development Bank Institute on the learning losses from exposure to lead-polluted sites in Indonesia. So, lead exposure, well, as we heard already at the start of this conference, is a big problem, especially in low-income contexts. And one of the reasons that this is concerning is because many studies find associations between lead exposure and low IQ. So by combining these studies in a meta-analysis, the CGD team has even found that, or even estimates that lead exposure may even account for over 1/5 of the learning gap between rich and poor countries. And an important polluter in these poor countries are used lead-acid battery recyclers. You'll hear a lot more about them in other sessions in this conference. What this looks like, you can see in the picture. So what happens is people will open the batteries with something like a hammer, take out the lead, and the lead needs to be smelted. And this actually often happens in open air. And so this then contaminates the area surrounding these battery recyclers. So these batteries are used a lot in electric vehicles and energy storage. And so because demand for these things are growing, this problem is actually expected to be growing over time as well. Now, Indonesia has a lot of these so-called U labs. Around 200 toxic sites have been identified in the past 2 decades. And NGOs like Pure Earth estimate that nearly 2,000 people are at risk around each of these sites, mainly through ingestion, because it contaminates water, it contaminates the soil that crops and livestock are grown on, and especially for kids, it's a risk because they put everything in their mouths. So what can I say about blood lead levels around these sites? Well, the global burden of disease data estimates that about 8 million children in Indonesia have elevated blood lead levels. This is about 10% of all children. This is not all coming from these ULAB sites, but there have been a few smaller studies that tested children's blood lead levels near these sites that also found levels between 5 and 26 micrograms per deciliter. But yeah, all of them find levels that are associated with decreased intelligence and learning problems. So a lot of studies find these associations, but what we try to establish in this study is how lead exposure from these ULABs impacts children's foundational learning outcomes. So the way we do that is by combining two different data sources. We take the toxic site identification program data from Pure Earth, which gives us the coordinates for 150 sites, and also lead measurements in soil or water around these sites. And we combine this with the Indonesian Family Life Survey, which is a longitudinal household survey representative for about 83% of the population. So, that gives us a big part of data for a big part of Indonesia. And in the rounds in 2000, 2007, and 2014, it included a numeracy test with some multiple choice questions that asked the respondent to do addition up to division and fractions. So that's the level of numeracy skills that you should think of. And this was asked to 7 to 59-year-olds respondents. So on the picture on the right, you see a bit what it looks like when we combine these data sets. In the red dot in the middle is a toxic site, and then these green dots are IFLS enumeration areas. So I don't have exact locations of the households. That wouldn't be great for their privacy, but I do have the center of the enumeration area. And especially in urban areas where most of these ULABs are located, this is quite accurate. So the average radius of such an enumeration area is about 1.5 kilometers. So we can still say pretty precisely how far away they are from these sites. Now, we do rely on the overlap between these two data sets. So unfortunately, we don't have IFLS data around all of these, around all of the sites that were identified by Pure Earth. We are actually even more strict within our selection criteria. So we take toxic sites that have IFLS enumeration areas within 3 kilometers. So a few studies that have studied the impacts of toxic sites found negative impacts within 3 kilometers mostly. So we want to make sure that we include that in our analysis. We also rely on the information availability of these sites. So we want to know the starting date of the ULAB site because we want to estimate we want to calculate what the age at first exposure of the respondent is. So there are many studies that show that in utero exposure and exposure before age 7 generate the worst outcomes for lead exposure. And so that leaves us with 14 toxic sites that we study. We take all the respondents around that toxic site within 10 kilometers to add a comparison group for those who are within 3 kilometers that has a similar socioeconomic background, but we still have a sufficient sample size to do our estimations. And on average for these 14 sites, 93 respondents live within 3 kilometers of each of them. So the model that we estimate is essentially a staggered differences in differences model. So each of the toxic sites in our sample started between 1975 and 2012, so at different points in time. And for each site, we determine which respondents were exposed between age 0 to 6 and which respondents were already 7 years or older when the site started. So that's the first difference that we look at. Then the second difference is the distance of the respondent to the site, which we divide into these three categories between 0 to 3, 3 to 6, and 6 to 10 kilometers. And so we compare these groups of, what we compare for these groups of respondents is their numeracy tests that they did in one of the IFLS waves. So in terms of the model, we regress the numeracy score on the interaction between age at the start of the site and the distance from the site, both these indicators individually. We include toxic site fixed effects to take out any time invariant characteristics of the toxic sites, and we include indicators for age at time of the test to take out any trends in test scores over age, and we include some additional controls like the respondent's sex and parents' education. We correct our standard errors for clustering at the enumeration area, and we also apply a correction for issues with these types of models that have been pointed out in the recent literature, which you can read more about in the paper. So to be able to say that we are measuring causal impacts of these ULAPs, we make two important assumptions. So one is that the correlation between distance to the toxic site and the test scores would have been similar between groups if there had not been any lead exposure. So the figure on the left shows that for people who live further than 6 kilometers from the site, the people who were exposed before or after age 7 showed similar test scores. And so that suggests that that's indeed, if there wouldn't have been that exposure, these test scores would have been similar between these groups. And as you move closer to the toxic sites, that's where you see where the learning gap starts to arise. The second assumption is that the correlation between age of first exposure and numeracy scores would have been similar no matter the distance without any lead exposure. So similarly there, if the respondents were 7 years or older at the time of first exposure, you see that they show very similar test scores between those who were within and further than 3 kilometers from the site. And as you are exposed earlier, you see the gap increase. So this already gives you a preview of our results. But what does it look like when we estimate our preferred model? You can see that in column 4 here, where the interaction between early exposure and living within 3 kilometers of the sites shows a learning loss of nearly half a standard deviation on this test score. Now, in one of my earlier papers, I looked at how much children learn in school on this specific test in Indonesia as they progress through their school. And so this loss is equivalent to nearly 3 years of basic education in Indonesia. And if you look at the estimate for those within 3 to 6 kilometers from the site, the estimate halves, but is still marginally significant and substantial. So what we show is a causal impact of these of lead exposure from these ULAP sites, and that early childhood exposure harms learning substantially. Now, my background is in education. And I know that a lot of governments are interested in improving learning outcomes, in fighting the learning crisis. So what I see is that investing in lead cleanup and prevention could substantially improve learning if we're able to reverse this negative impact that will yield gains comparable to the top 10% most effective education interventions. And it would reach a lot of children, if you allow me to loosely extrapolate the impact to exposure from other lead sources. But yeah, if we focus on the children living around the ULEP sites, then we conclude that stronger regulation and more rigorous enforcement around these sites are urgently needed. So, thank you. Looking forward to your questions.
All right, thank you very much, Emily. We're going to go through the 3 presentations and do Q&A as a group here. So we're going to move directly in to Gerald DiPapa, who is a postdoctoral research fellow at Georgetown University here in town, I was just learning, between the McCourt School and the Economics Department. And Gerald has causal evidence on the impact of lead, again, on education, from a Kenyan context with a different kind of natural experiment. And I want to pay attention here. I think there's an interesting contrast, which I'm going to give away my question beforehand about the contrasting kind of age of exposure and how we should think about that between what Emily just presented and what Gerald's about to present. But Gerald, please, the floor is yours.
Thank you. My name is Gerald DiPapa. I'm glad to be here to talk about this important work that hopefully kind of is a part of information to what's going to be discussed over the next 2 days and beyond. I'm going to do something unconventional and tell a quick story. About 20 years ago, a woman in Mombasa, a city in the south of Kenya, received a phone call from a school that her son was attending. So she left her place of work and went to fetch her son. He took the son to the hospital. The son, there was kind of a few tests that were done, blood work tests on the son, and nothing came out of the test. It was negative tests. Of course, they were treated of the symptoms that were presented, and they were sent away. And so that happened for a couple of weeks, and after a few weeks, she decided, well, I'm going to go back, but this time I'm going to try see if I can get an alternative physician. So she went to another physician who, after reviewing the symptoms, asked, where do you work? What kind of work do you do? She told the physician that she works at a battery recycling plant and light bulbs. And so we know recycling in good light for the most part, and in these cases we see that things like having a lot of landfills could be detrimental to the environment, and so reducing that would be appealing, and so those are kind of taken as benefits. And we can also take recycling to be a source for employment. And of course, there are many other benefits here. But these benefits are optimized for the most part when recycling is done safely, right? And so how rich economies actually get to this goal is to kind of tighten regulations so that they can internalize the costs associated with that. Now, turns out these benefits are kind of universal across poor and rich countries, and so are the risks, right? And so if farms are looking to be profitable, oftentimes they shift to unregulated markets so they can cut their costs. Now, sub-Saharan Africa, unfortunately, most recently has become a hotspot, and governments in these countries or authorities in these countries, unfortunately, politically, have been forced to embrace these farms and let them operate unregulated for the most part. But the question is, at what cost? At what cost? And particularly, what are the impacts of this lead exposure due to recycling on human capital development, which is a really important economic outcome? We also know that we kind of struggling with the lack of learning in sub-Saharan Africa, and the concern is, how can we turn this around? Is lead a part of the story here? Is it a contributor to the learning stagnation in sub-Saharan Africa? Of course, there are many other factors that are involved in driving learning in sub-Saharan Africa. And so it's not that obvious to say, oh, well, lead is actually part of the story. And so in this paper, what I'm going to try to do is I'm going to seek to understand how random variation in lead exposure due to these recycling plants impact learning in Kenya. And I'm going to leverage this context where there was a sudden environmental quality change in 2007 when tens of recycling plants, of course varying in size, were introduced in the market. To do that, I'm going to use an individual level student test scores from a national school, secondary school rather, qualifying exam, which is a high stakes exam, decides where a student is going to go for secondary schooling after primary. And I'm going to use a matched diff and diff to identify my impacts. I'm going to show the kind of results for the matched event study as well. What I find is that lead exposure due to recycling actually reduces student test scores by 5% of a standard deviation in Kenya. And what is interesting about this number is that it is similar to the effect size about the same ballpark. Effect size of school-based programs, the conventional ones we're used to, that target improvement of learning in these regions. Okay, so that's an interesting and it's sizable effect. Now, okay. I had a picture here that I wanted to show. If you can click on that UW link, please. So this is kind of showing what the context looks like. So at the back there, that's a recycling plant in Mombasa city, south of Kenya. Apparently, where that lady that I was talking about worked. And the perimeter wall there separates the recycling plant with the households, right? So these are residential areas. So you can see the little kids there playing outside their house. And you can imagine that there is emissions from the plant which then settle on the ground, on the rooftops, and some linger in the air for a bit. Just back. Can you hit back there for me for a second? Sorry. Back. Oh, sorry. Can you hit the link back there? Yes, thank you. Now, in 2007, about some tens of these recycling plants were actually opened across the country. Of course, they vary in size. At any given point, 95,000 students went or attended schools within 4 kilometers of these recycling plants between 2007 and 2010. Now, given that the emissions are in the air and on the ground, as you saw there, of course, not just immediately after the plant, but of course, all of that is blown out to a distance away. How does that get into the kids? Well, for the most part, it's through inhalation and ingestion. And of course, children are even much more vulnerable because of their hand-to-mouth behavior, right? So, I want to get that, play with it, and put it in my mouth, right? So they kind of ingest this and inhale a lot of this. And of course, their organ systems are also not developed enough. And so their mechanism to metabolize lead is relatively ineffective. Okay. From that, it goes, lead is then absorbed into the bloodstream, then gets deposited in important organs, including the brain. Of course, within the brain, then this impedes development of the brain, disrupting cognition and short-term memory. Now, I'm gonna leverage the variation due to the severity of exposure to schools to then run a difference in differences regression here that compares children attending schools within 6 kilometers of the battery plant, recycling plant, versus schools outside of 10 kilometers, but within 20 kilometers. And children who are exposed to the lead pollution for more years, the younger cohort, versus the older cohort who are exposed for much less. Now, I say 10 to 20 kilometers here. I'm going to use I'm going to follow Heimler to kind of do entropy matching between these kind of schools away from the plant and those schools that are close to kind of make sure that the socioeconomic variables are accounted there. This is my specification here. I'm going to just go over that really quickly here. The learning outcome here for the student is YIST. This is student I in school S in exam year 2, and the battery of control student level controls is the X there. Recycling plant here is an indicator that takes the value 1 if the student I school is within 4 kilometers. And I forgot to mention 4 kilometers in the sense that she had mentioned that most studies are 3 kilometers. So I want 4 kilometers to taking into account that they're not regulated for the most part. So the number 3 kilometers kind of associated with mostly the regulated ones. So potential exposure here is an indicator that takes the value 1 if student I belongs to the younger cohort. I'm going to class to standard errors at the school level and then also for robustness at the plant level. This is kind of the event study version of that. Just to kind of point out reference category, there is the exam year just before the battery recycling plant were opened in 2006. So to measure learning test score data, I'm going to collect data from the Kenya Certificate of Primary Education, which has test scores and of course other student attributes like gender and year of birth. And I also have a data set that I got from the World Bank, Kenya Primary School data set that helps me to kind of do the entropy matching, right? So it has attributes of schools, number of classroom pupil-teacher ratio, etc. Also, the data set from Pure Earth that helps me to geolocate the battery recycling plants. Just to kind of go over the findings here really quickly, these panels here show the impact of lead exposure on standardized test scores. And as you can see, the sort of the coefficients are fairly stable before the opening of the recycling plants. But right after that, we can see that there's a drop in test scores. And that is sustained throughout the years. And the panel on the left is with a 4-kilometer radius, but then I do that with an 8-kilometer radius and 6 and 8-kilometer radius as well. You can see there's a reduction in the size there for 6-kilometer radius. This impact dissipates after the 8-kilometer radius in this analysis. So really quick on potential mechanisms there, health channel and the resource relocation are the kind of channels we think these impacts are channeling through. And in conclusion, excuse me. In conclusion, exposure to battery recycling plant, lead exposure, I find reduces learning, and this is a real threat to human capital development in sub-Saharan Africa, especially given that there is already a lot of other things driving that situation. And this impact, like I said, disappears after 8-kilometer radius, and this is to say that it's not about whether or not these recycling plants should open. What I'm arguing is that it should be the case that we want to safely open them to internalize the costs. Yeah, and some areas of further research, and I'm sure there's quite a bit of work already happening in improving our monitoring systems, which then gives us the data to establish the extent to which exposure is among the children that allows us to then structure our interventions. Thank you.
Have a seat here.
Thank you very much, Gerald. We've covered, I'm going to come back to you with questions about ages, but we've covered Indonesia and Kenya, and now we're going to go to Brazil, I believe. So our third presentation, with a similar methodological approach and a set of questions around the impacts of lead exposure, is going to be from Mikey Jarrell, who's a PhD student at University of California, San Diego, where some of my favorite development economists work. Mikey's also involved in the RFP that CGD has put out for new ongoing fieldwork in lead. So we're excited to see the stuff he's producing. But please, Mikey, take us to Brazil.
So I'm working on this project with the rest of the lead battery team who are here. Nathan, can you stand up? This is Nathan Lazarus. He's also a PhD student in the economics department. He's at MIT. And then we're also working with Amshel, DeRothschild, stand up, give a wave. He didn't get author credit. He only started helping us with this the other day, so he didn't earn it. Also, Michael Cleary, stand up. He also just started helping the other day because he just finished his master's program, so give him a round of applause. And actually, this paper is kind of the least interesting of the things that us battery people are working on. So if you found this exciting, just wait till you hear what else we're up to. This started as a class project that I was working on with David Vargas, who is a classmate of mine at UC San Diego. I think we've established pretty concretely. In fact, imagine you were a prime minister or something in a developing country, and you had just listened to these presentations. I think you would come away pretty convinced, A, that lead exposure is a big deal and a big problem and that governments should be taking action. You also might be convinced that, in particular, battery recycling, when done badly, could be a major source of this lead exposure. But then what should you do about it? And I think that's kind of the motivation I want you to have in mind as we go through this. So what do we know? Well, we just saw what we know. There's a growing body of evidence that as I just said, that battery recycling can have pretty serious impacts on health and learning outcomes. This seems bad. How bad? Apparently, we're going to have more on exactly how bad we think lead exposure from battery recycling is tomorrow. I think there will be some more talks by Lee and Jenna and other people. But what should you do about it? So you could look and see what rich countries have done about battery recycling. But I think most of those options are off the table because they involve very expensive machines and monitoring technologies and just things that developing countries may not have the capabilities or budgets to deploy. So then you're stuck looking to see what the other developing countries have done about this. And the answer is pretty much nothing. So we don't really know what works on how to face this challenge. There are two exceptions. One of them is China, who attacked this problem with great vigor. We're working on analyzing the impacts of their approach to this problem. Stay tuned. Maybe we'll have some results someday soon. The other country is Brazil. So we're gonna focus on Brazil. We're going to see what Brazil did and whether it worked. So what did Brazil do? This all comes from very extensive research by Hugo Smith, who is also on the battery recycling team. He's not here. He'll be here tomorrow. He just graduated from the University of Chicago as an undergrad the other day. So this is an analysis of all the policy documents and conversations with policymakers and industry leaders to see what did Brazil do and what were the, how was this enforced. The major components, now if you want to see the details of this, check out Hugo's Substack. This is Lead Battery Notes Substack. If you just Google that, you'll find it. A lot of great stuff on lead battery recycling and its impact on lead exposure. The main points here we're going to keep in mind. There was a tax break. So why a tax break? Picture Brazil as being a country where there are two different kinds of recyclers. Sort of the formal ones, these are big, nice factories, and the informal ones, they're going to look more like what we saw in the photos from Gerald. Now, taxes are going to be paid by the formal sector. They're not going to be paid by the informal guys. If we think that the formal ones are better in terms of pollution reduction, then all the tax is doing is giving them an unfair advantage, right? So the bad guys are not paying the tax, the good guys are paying the tax. We're going to get rid of the tax, okay? So they got rid of the tax on, the value-added tax on purchasing used batteries, okay? That's the big one here that we're going to focus on. They also did a reverse logistics thing. Think of this as like when you bring your glass Coke bottle back to the grocery store and they give you 10 cents. They kind of did the same thing for batteries here. They raised the emission standards. They also did this producer responsibility thing, the Instituto Brasileiro de Energia Reciclável. I just wanted to say that. This sort of functioned as like the intermediary between the industry and the government to facilitate, compliance and regulation and all this stuff. This really came into effect in 2016, so we're not going to really look at the impacts of this, but I think this is a fascinating sort of piece of this legislation, and I think it's sort of the key to its success moving forward. We're not going to really be able to analyze in what way specifically it was beneficial, though. So here's the kind of the main point of the legislation. They wanted to formalize the industry, right? We think the informal guys are doing a bad job, and the formal guys are probably doing a better job. And what happened around 2005 when they started with the tax break, we see the total number of people working in lead recycling formally, as formal employees within this industry, more than doubled, okay? So this is, we're not going to argue that this is like 100% bulletproof causal stuff, but I think it's pretty suggestive that this industry was growing, and it seems to have been growing most rapidly immediately after the policy change, okay? So we think, yes, now there is more formal recycling happening, and that probably means that there's less informal recycling happening. What is this going to do to pollution? Well, kind of depends. How much better is the formal recycling? Okay? That's kind of the interesting question that we would like to try to answer here. But we don't have pollution data, and we don't have blood lead data, so it's going to be hard to do that. So we're going to look at these other things that we think, we've seen from the other studies. These health outcomes, learning outcomes, they seem to respond, as we've seen, to blood exposure. So if these outcomes move, if we see changes in health outcomes, if we see changes in learning outcomes, that points to a change in pollution. Okay? We're going to do this using a difference in differences strategy. You have now seen this 3 times. It kind of looks like wizardry. So I'm going to do it. I'm going to give you what I think is going to be the least painful econometrics lesson of your life. Here's how a difference in differences works in the simplest possible version. Here is a town. In Brazil, we're going to be working at the level of the municipality. For the Americans, think of this as a county. Okay? Within this county, within this municipality, we have a recycling factory and a hospital. Okay? And before 2004, this is sort of what the world looked like, okay? And we actually got some outcomes. We went to the hospital, we asked them, hey, what fraction of children who were born at your hospital were born underweight? And we got this number, 0.03%. I made this up. And then in 2006, we came back after that tax break thing was implemented, and look, the factory is so much bigger. Holy cow. And we checked what the birth rate, the underweight fraction, how many of these kids were born underweight, and we got the same number. So we think, if we do this sort of before and after comparison, it looks like the increased size of the recycling did not have any effect on the birth rate. You see the problems with this analysis, right? A lot of things could have changed between 2004 and 2006. Medical technology improves, maybe the Brazilian government increased its budget and spent more on these hospitals. Any number of things could have happened. Let's try a different strategy. Let's compare 2 different municipalities. Here's that first one we saw that has the big recycling factory, and we remember our 0.03 number, and we're going to compare that to a control. This is a control municipality. They don't have a factory. And we're going to find that the number here is 0.05. And we think, oh, actually, the factory is good for health. The underweight fraction went down. Again, you see the problems here. So here's the solution. We do a difference in differences. We take the treatment municipality, so the one with the factory. We see how this changed over time. We see that it didn't change at all, so the difference is 0. Then we look at the control municipality. How did this change over time? We went back and we found that number. It happened to be 0.09 in the past. Okay, so actually this one went down by 0.04 over this time period. And we see the difference in the differences. Our outcome of interest here, the number we're looking for actually is the bottom right corner. It shouldn't have a negative. That should just be 0.04. Point is, if we think that the way the control evolved over time would have been representative of the way the treatment would have evolved over time, then that's our number. So there's the mystery. I hope that cleared that up a little bit. So we're going to do essentially that. That's the concept, slightly more complicated. We're going to, let me go back here. We're going to find treatment municipalities. Those are going to be places in Brazil that have battery recyclers or battery manufacturers. And we're going to compare that to control municipalities that don't have these things. And we're going to look at these health outcomes and these learning outcomes. So what do we see on health? We see actually, look at that, health seems to have improved, although I would kind of call this nothing. It seems like this line is pretty flat. The difference between the treatment and the control municipalities does not really change very much as we pass the vertical dotted line, which was the start of the policy change. Okay? So now let's look at learning outcomes. We see that learning seems to have gone down. Okay? So this kind of looks like something, although perhaps before the policy change started, it was already kind of sloping down, so I don't totally trust this yet. So we're going to do a slightly more sophisticated thing, which I don't entirely understand. Nathan did it. He went to MIT. I trust him. And we're going to get some more specific numbers. What we're going to find is essentially a meaningful, a statistically significant, but I would say overall pretty small effect of increased employment. So if you were to increase the number of people working at a battery recycling plant, which we think is representative of that plant getting bigger, right? So if we think the plant gets bigger, we will see the birth rate, the low birth rate percentage increase very slightly. We're also going to see the education scores, the fraction of students who pass the year-end class goes down slightly, although this is only significant for the younger children, although we would expect that. And overall, it's hard to say exactly what we learned. We learned that, okay, the policy did work in sort of the most immediate sense in that it increased the formal output. And we think it probably decreased the informal output. But again, it's informal. The definition of informal is we don't have data on them, okay? So we don't know for sure. We don't see huge evidence of these sort of unintended consequences that we were afraid of when the formal sector got bigger. So some small effects on health, some small effects on education, but overall I would say that if the benefits were truly really large, if the benefits are as large as what we saw from Emily and Gerald, on what would be the impact of reducing the informal recycling, these benefits would clearly outweigh the costs of the formal sector getting bigger. But we're going to try in the future. I think there's avenues to make progress on this with more data, with more creative approaches. How can we try to figure out where were these informal guys? Did the people in those areas benefit when they went away? We can also look at wages of people who worked at these places, and we're going to try to tie in China and see if the results are similar there. And that's it.
seat. All right, excellent. Thank you very much, Mikey. So as you saw, 3 kind of methodologically comparable presentations trying to pin down this question of causation. I mean, I think it's an interesting bridge, the 2 halves of this session, right, where we have these big global numbers about impacts and some questions, or at least I have questions, about the causal links, underlying some of that. And then we have you folks wrestling really hard with those questions of causation. So the first question I wanted to ask before we turn it up to everybody else was, as advertised, in your analysis, Emily, it was sort of built in this assumption that it's exposure in the very early years that matters, right? And if I understand right, the way you're using the KCPE in Kenya, Gerald, it is exposure that I'm getting in 7th grade affecting my 8th grade test scores, right?
Yes, for the older folks.
For the older. Speak to me about what I should take away from this. Where do I come out at the end? Do I believe only the younger exposure matters? Do we think we've got, can we reconcile this with what Gerald's finding in Kenya?
So your exposure's in 7th grade?
Well, it cuts across. So you can imagine that in 2007, which is when these recycling plants opened, there were individuals who were in 8th grade, right? So those are probably not impacted as much because they were doing the exam that year. And individuals who took the exam in 2010 ended up being exposed for about 5 years or 4 after the recycling plant was open. So sort of the length of exposure, and of course at the beginning of the exposure, they were younger compared to individuals who were exposed in 2010 who were much older and they were just exposed for a little bit.
Okay, so you do have that variation in length of exposure.
Yeah.
Right. Whereas you're finding in Indonesia null effects for the older cohorts, right?
Yeah, so we do find for those people exposed after age 7 that there's no difference in the test scores for those who are near the site compared to further away from the sites. I'm trying to think of ways. Yeah, so I don't want to claim that there's no impacts on people who are exposed to lead after age 7.
We're not going to make you say that. So
okay. But yeah, in terms of the test that we measure, which is these foundational numeracy skills, that's where I don't find these differences. But these are very, very basic numeracy skills. So perhaps if you have a test where like the one you look at, like exams that are way broader, measure skills way further down the line, that you can still see impacts on tests like those.
A second question, which I think could apply, I'll ask Mikey actually, but maybe it could apply to any of you. I'm trying to bridge the gap between this sort of global macro modeling and the causal parameters all of you are producing. And one thing that I often find is missing in all the work that you folks have done to get at causality is I don't actually have a parameter that links, exposure to outcomes, because often you don't have a BLL measure, you don't have a bone lead measure. Can you do anything to tell us about whether the effects you're estimating are consistent with the kinds of elasticities that we're getting from the more scientific literature?
No. But I think that's a ripe area for future research, and I think that's exactly one parameter that we're going to try to estimate with the study that we will be soon undertaking in Nigeria. I think without any sort of without the blood lead numbers or without the pollution numbers, I find it really hard to make heads or tails of what we should be expecting to find, especially given, just even within a country, the variation in recycling quality is astounding. And so, it's hard to extrapolate from the existing literature, I would say.
Yep. I should add, when I started looking at these about 5 years ago, or 6, I should say, there was no VLL data. And so I was frustrated. So how can I do this, right? Because to me, I felt like it was an important topic. And so I had to see ways to kind of get around this constraint. And one of the ways was to kind of use the available data. And it's very rich data, to be honest. You have data in different sectors, education, and of course these mappings from other parties that could allow us to do something, right? As we await for monitoring systems to come into place so that this data can be collected, we can sit on our hands and wait until we have that data to get our systems working for us to kind of analyze the data and make some progress.
I was also wondering, because you're using Pure Earth data too, right? Does it also include the lead measurements?
Yeah, the soil lead levels.
The soil lead levels. So I was wondering, maybe we can deduct something from that data to find correlations between impacts and the level of pollution.
Yeah. Okay. Well, actually, let me just put in a plug. I mean, the other option, if you really believe your identification strategy, you really think you've nailed the reduced form causality, we can go back and collect more bone, lead. We're doing that under the CGD. CGD is doing that under the CGD research program for at least one of the studies you cited, the Mexico Tanaka et al. Paper. Okay, let me open it. I promised to turn my body to this half of the room this time. So Lee wants to start, and then young woman here. Rory, pass the mic to Lee, and then we'll come up.
Thanks. Hi, Lee Crawford here at CGD. First question is, I'm going to be taking all of your studies quite seriously tomorrow and thinking about the implications for that. But I still struggle with this distance parameter, but it's 5 kilometers. Like, that's really far. That's like to the other side of the Capitol building from here if we were recycling here, or to like Ronald Reagan Airport. It's a huge area, and like I believe your studies, but it's just hard to. So I'm curious to see how you think about that, the science of that. And then second, let's say you were leaving here and the president of Kenya and Indonesia just happened to be in the elevator. What would be the one thing you'd tell them about, how do you fix this problem?
Not allowed to answer yet, though.
Something else.
Okay, this is again a memory test. So you've got distance and the president. The young woman in the black up here, black shirt here.
So my question is for Mikey. So I know you said that there's really no definition for what an informal sector entails, but if it was defined and categorized, because I know that this is something I struggle to account for in my work as well, but I know that there's a huge difference in like the top tier informal recycling versus what happens in the bottom tier informal recycling. So if it was categorized and more defined, do you think it would make a significant difference in the differences method that you're working on? Mm-hmm. Yeah, thank you.
Diff. And one more in blue just behind you.
Thank you so much. I'm Ryo Doya from Hokkaido University, Japan. So my background is the analytical chemistry and also toxicology. So, and now we are actually trying to launch a new monitoring and capacity building project in Southern African countries. And you are the causality side of person. And now we are trying to produce data sets of some environmental and also the human and animal blood lead levels. So what kind of data set would be more useful to connect or to be utilized in other future researches, and also to talk to the politician? I would be very appreciative your inputs.
All right. Yep. I'm getting signals about time, so let's come back to the panel on these. One of those was for you specifically, Mikey. The other, I think, are across the panel. So why don't we start with you, Emily, and go down the line here. You can pick and choose. You don't have to answer all of them. Yeah.
All right. I'll try and answer these questions quickly then. So about the thresholds on the distance in which these sites have have negative impacts. I think these ULAB sites, they do like lead smelting in open air. There's wind, there's water that takes the lead down. If you grow any crops or livestock, people will eat from that around the area. So I think that you can reach 3 kilometers probably quite quickly that way. What I would tell the Indonesian Prime Minister, that is a difficult question, and I'm hoping to find answers in this conference for solutions. But especially since many of these ULABs are informal, but I know that NGOs like Pure Earth work on cleaning up these sites and trying to limit the pollution from them. So I know it is possible. But it's still a question.
Gerald?
Yep. I think she talked about the wind and sort of the rain washing down. And you can think about the story I just told, which is actually real. The woman walked there, but of course lived way off, and the child got sick, and really sick, because the blood levels were then found to be high. And so in that respect, that we expect for the most part in that locale that quite a bit of people are going to be impacted. And I mean, kids attend the same school, so they can carry that to school as well. And if a school is closer and kids are coming from way out to that school that's closer to their plant, then they're going to spend a lot of time there, and in that way they get exposed. And for the president, I think that this issue is multi-sectoral, and you can think about what we just kind of try to measure here. We want to see how this impacts learning from the education point of view, right? And it turns out something health-related is actually what is driving the learning outcomes. And so there's need to sort of break the kind of the silos that we've been operating in across ministries. How about we make data available across ministry and collaborate on kind of thinking about how we can layer the data pieces that we have. Well, we have health data, we have education data, we have economic data. If we can layer that up, because I'm the president and I could order for that to happen, then analysis could happen that allows for us to get some intelligence, even if it's correlational initially, and then of course get the tools to sort of then infer causality. That is what I should say, but I missed her question.
In the interest of time, then I'm going to see if Mikey will take a shot at it.
The difference in categorization. I'm not going to claim to be the expert on this. The estimates I've heard on sort of the difference in pollution rates across between formal and informal, I've heard between 5 and 10%, but these are, as far as I can tell, little more than educated guesses. This is one number that we are also going to try to estimate in one of our upcoming studies, so I agree that it's a super important question.
All right. Thank you to all of our panelists. Excellent series of presentations, and to Sandra, who already went back to her seat. And let's have one more round of applause for the group. Stay seated, and Rachel's going to tell us what next.
Again, another logistics note. So we have our final session of the day starting at 4:30. So we'll see you back here in a few minutes, and after that, the reception. And again, if you can look under your seats, and if you have any detritus, we appreciate if you can throw it out with you during the coffee break. If you are on the next panel, please meet us outside to get mic'd up. And please return your mics to our nice AV people. Thank you, everyone. See you in a few minutes. Okay, hello everyone. Welcome back to our next and final panel discussion of the day. If everyone can come in and take your seats, we appreciate it. All right, wonderful. So this panel is going to be on methods and practice of lead surveillance. So how do we find out how much lead is out there, and as a starting point to craft our response. One note I forgot to mention earlier, and to the chagrin of our communications team, we encourage all of you to post about this event on social media. We will do our best to find you, retweet you. We don't have any particular hashtags or anything like that, but we very much welcome sharing on social media, and we're very happy to help amplify any postings or messaging you have there. So for proceeding with this panel, I'd like to invite up to the stage Brett Erickson, our moderator for this panel. Brett is an adjunct professor at New York University in the Department of Global and Environmental Health. He's also a project coordinator at the International Civil Aviation Organization. He has a bachelor's degree in comparative cultures, a master's degree in urbanization and development, and a PhD in environmental sciences from Macquarie University. And for those of you who've been in this space, he's behind many of the seminal pieces of work that help shape all our thinking. So Brett, up to the stage and over to you. Oh, you're over.
Sorry. Hi. So I'm going to introduce. I'm going to bring up Ilu and Yatin Pimple, and they're going to talk about health systems capacity. Ilu is a senior technical advisor at Vital Strategies with a background in environmental epidemiology, research coordination, policy analysis, and technical expertise in toxicology and environmental risk assessments. She provides technical leadership and works closely with country teams to address lead poisoning at Vital Strategies. Dr. Liu holds a PhD in environmental health science from the University of Albany and a bachelor's degree in preventive medicine from Southern Medical University. Yatin Pimple will follow E. And Yatin is a senior program manager of the South Asia region at Vital Strategies. Yatin is a public health physician, has over a decade of experience in areas of system strengthening, public health surveillance, and advocacy. Dr. Pimple holds a bachelor's degree from Maharashtra University of Health Sciences and a master's degree in public health from the University of Pune. Without further ado, E. Thank you.
Thank you, Brett, for the nice introduction. Today I will start the talk by giving a framework, no formula anymore, but a framework of our approach to conduct capacity assessment to establish blood lead surveillance, particularly in Maharashtra, in India, in Indonesia, in Peru and Colombia, as well as Kyrgyzstan. So I'll start with the framework, and I'll pass down to my colleague Yatin to talk about our example in Maharashtra state in India. Okay, so I think many of us already touched on why lead poisoning is a widespread issue, but it's often unseen because of lack of populational data. And lead surveillance or representative testing is what fills this gap. But before we enter these countries, one of the main things we often start with is to assess what are the laboratory capacities and the public health infrastructure to support this work. So the two main questions we want to answer in our capacity assessment effort is, does the country have enough adequate testing capacity to support such effort, whether there's a need to establish or improve the capacity, and also what is a plausible and sustainable approach for designing blood surveillance in the country. And with this information, it will also help us to inform our design of a customized national or statewide blood lead surveillance plan with the government. So as you can see that our capacity assessment report generally included 5 components with different key questions in mind. So we generally start with the information collection through a literature review, as well as database searching, as well as interviewing our local experts. And for the remaining information, we try to collect this through laboratory surveys, as well as stakeholder workshops. We have developed a range of templates to guide our country teams, but I do want to emphasize that each of these materials and the approach have been heavily customized with input from our country team as well as the local experts. So it's a real team effort. So the first component is to answer, does the country or state have the adequate laboratory resources to support representative testing or surveillance? We start first by looking at the national accreditation database if they're available, and by reviewing the previous studies that assess blood lead levels in the country to see, and also with the local experts to see what are the national or state laboratories. And for the ones that we identified, we then collect information to assess what are their capacity and their quality. And for those that with limited testing capacity or national laboratories identified, we try to understand whether there's any interest or opportunities to establish laboratories to test the blood lead levels, whether there's also already use and validation of portable analyzer in the country, and also what is the testing, what is the capacity to test potential some blood samples abroad. So for the laboratory survey template, our questions mainly focus on assessing the following components. So the key question we want to answer is, are there public health laboratories that are affiliated with the government? What are the equipments and analytical methods, how sensitive and accurate they are? What is the testing cost and maximum number of samples that the laboratory can analyze? What is quality control protocols, whether there's stable reagent supply and trained staff, and to ask the laboratory what might be the needs to expand and improve their laboratory capacities. As on the right, you can see an example of a customized survey that was distributed through Google Forms to the Indonesia laboratories. So for the policy landscape, there's 4 main questions that we want to know. Who are the key players to engage in designing the blood lead surveillance in the country or the state? Who are the main user of the data? Whether there is any political support or opportunity to start such a surveillance effort, and if so, what will be the main question that the government are interested in answering? Whether that's source of lead exposure, whether that's a distribution, or whether that's tracking progress. So for the public health surveillance, we're trying to review the previous BLL studies to understand what has been some existing efforts in the country and what are the levels that there have been seen, what the measurements that have been used, and also what the existing surveillance system. So here is an example of the Civilhila from Colombia, where they track acute and severe lead poisoning cases and intoxication. We also are looking for opportunity for thinking about long-term surveillance efforts, to think about whether there's national health survey that can incorporate lead assessment, or whether this can be part of the routine care for the children. And we also are looking for health information system that can incorporate surveillance data to inform the policy decisions. And there are 2 other components. We also want to understand what is clinical management capacity in the country. If a child was identified with elevated blood lead level, are they able to seek care? What is the level of action? What is the protocol to follow? And whether there's any gaps in training the health professional in addressing or managing lead exposure. We also assessed what are some risk communication efforts in the country and how we can use these to disseminate our findings. And 2 examples are here from Bogota cities in Colombia, where they have created infographic for the public and also annual report in lead exposure in their children. So I'll pass it on to Yatin to explain a bit more about the findings and implications in Maharashtra.
Thanks, E, and I'll take support of the podium because I'm jet lagged, so sorry. So in Maharashtra, India, which is where the city of Mumbai is, the capacity assessment supported us or helped us in various decision-making processes. When it came to stakeholder coordination, we thought it's essential to have a intra-departmental technical working group within the health department, which can guide the designing and implementation of surveillance activities. But when it comes to cross-sectoral coordination, we thought it's important that the local pollution control boards are also important media where different ministries convene. So they have the capacity to convene Ministry of Environment, Ministry of Industries, Ministry of Public Health Engineering Department, etc. For public health surveillance, we provided a set of options to the health department, and based on the options, the department thought it's better to do a statewide representative sample, wherein we are right now collecting samples of children between 1 to 6 years of age group. Laboratory capacity, of course, we'll talk in detail in the next slides. Capacity building, there are no national guidelines as such in India, also Maharashtra. But as per the national list of essential medicines, there are 2 chelating agents which are needed to be in the healthcare facilities. So we thought it's essential to build the capacity of healthcare professionals so that they can early identify, monitor, and treat the lead poisoning cases. So this was the overall government coordination structure within the health department, whereon we placed different health agencies as per the project activities. So for overall coordination, we placed the health commissioner. Then for surveillance, we have state surveillance unit, state health system resource center, which is a technical body, and the state family welfare bureau, which has the child health department. For laboratory capacity, there is state public health laboratory, but they don't have the capacity to test heavy metals. For home-based assessment, there is Ministry of Environment and the Pollution Control Board. And for training, there are different local NGOs, institutions, Department of Medical Education and Research, which can be onboarded to increase the reach of the training. So we provided the set of options, and these are the options. There are ongoing disease screening or surveillance programs. So for example, there is Early Childhood and School Health Screening Program, which is known as RBSK, which already does the screening of children for 4 Ds, which is basically defects at birth, diseases, deficiencies, and developmental delays. For adult age group, we thought it's better to have the National Program for Prevention and Control of Non-Communicable Diseases, because they have NCD clinics who screen adults for early detection and treatment. And then there is IDSP, which is a flagship program of the National Center for Disease Control, which is responsible for overall data management. They have a platform known as IHIP, Integrated Health Information Platform. But for now, the government has decided that they will do a statewide representative sample, which is representative of the population. Then we identified the laboratories which are mostly private and academic in nature, and they are costly. So for the baseline surveillance, we are using a portable analyzer, which is also, and for a subset of population, we are doing venous samplings to validate the results. So on the left, it's our program website. You can take a look at the website, and on the right, there are different. It's a project website, and you can take a look at different reports from different countries. And so Vital Strategies and Pure Earth, we thank the local ministries of health for providing us the opportunity to do the capacity assessment. And we are also grateful to the donors. And these are the contributors from both Vital Strategies and Pure Earth. And we have Jessica from Colombia, who has done the capacity assessment for Colombia. So you can also reach out to her. Thank you.
Thanks so much. Next, we have Dr. Vinaya Gamurthy. Dr. Vinaya Gamurthy is an assistant professor in the Department of Environmental Health Engineering, Faculty of Public Health in Sri Ramachandra Institute of Higher Education and Research in Chennai. He possesses significant expertise in conducting large-scale population-based studies, investigating toxic exposures and their effects. He's looked at manganese, he's looked at polycyclic aromatic hydrocarbons, and he'll be presenting today on a study of 700 children and 100 pregnant women in Tamil Nadu. Dr. Vinaya Gamurthy.
So good evening, everyone. Thank you, Dr. Brad, for the nice intro. So I'm going to explain our experiences in the statewide lead surveillance and also the data which we have generated from like 727 children and 78 pregnant mothers. So I'm from the Tamil Nadu. If you can say that it's in India, the southern part of India. It is one of the largest, highly industrialized state, second largest economy, and contribute to 8.8% to the national GDP. And also it's hub to electronic automobile sectors and industries like textile industries as well as IT. So it's also known high for agriculture industries, agriculture. So the background, why basically we want to do and lead surveillance in Tamil Nadu. If you look at model estimates, suggest average blood level in Tamil Nadu is 5 microgram per deciliter. That is one. So, but there is no statewide representative data available to verify these model studies. Model studies is like only if you look at Niti Ayog, that is a CSR Niti Ayog 2022 report. That is a meta-analysis of the already published data. And then the ROI 2009 is 11.4, it indicates, and the unknown is Mohan 2014 is 11.8. These studies are, it might be children for unhealthy children or children living near the hazardous waste sites. There is no any large scale study representing the healthy children across Tamil Nadu. So this was the first study that looked at with a large scale study looking at the BLL levels, and also it went on to find out, try to find out the sources. I am presenting only the BLL levels, the research that we generated from the BLL because of the time constraints. So as I said, quickly into the study design, if you look at, we have selected from Tamil Nadu 7 districts we have selected for this study, a combination of convenient as well as randomization. The convenience are districts are convenient and the blocks are conveniently selected, whereas the children's as well as the villages are randomized. So here are the process. You can say that as the first is 0 day, we go and get the permission of the households for the BLL testing, and then the next day they come to the testing center. It is done either in a public health the hospitals or in community centers. So we do the risk assessment questionnaire as the informed consent, and then we went on to test the blood level using a capillary testing. That is the letter 2 we used for testing. We get results in 3 minutes. So summary of the findings. So that's the study design which would basically help others who are also planning for doing this kind of testings. So distribution of blood level among children in Tamil Nadu. If you look at, we have 33%, 39% is above 5 microgram per deciliter. 33% comes in 5 to 9 range, and 6% comes in 10 to 19%. If you look at other studies published, Bihar, for example, Yi et al. Has published that paper, and they had above 10 to 19, 1 in 5 children in Bihar having in the 10 to 19 range. But then if you look at, for us, it's something around 6%. So average BLL high, if you look at the range distributions based on the BLL distribution among the age groups, if you see, the older age group had high BLL levels. If you look at 5.3 in the 61 to 72 months, 5.3, the rest is 4.3, 4.1 in that range. So we also went on to check the percentage of children in the elevated BLL by districts, how the distribution is there across the districts. Districts like Thiruvallur, Chennai, Kanchipuram, which are the urban areas, have a higher BLL than the rural areas, 56% and 46 and 42. As we go towards the rural areas, we can see that the reduction in the BLL levels. And greater than 5 microgram per deciliter, it is 56 in the Thiruvallur, and in the greater than 10 microgram per deciliter, it is 11. So it's Thiruvallur and Chennai are almost in the rural, falling in the rural areas. Chennai is a rural, and Thiruvallur and Kanchipuram are Chennai and Kanchipuram are urban, and Thiruvallur semi-urban areas. So lead level among children by urbanicity. So we learned, then we went on to assess whether there is a difference between rural and urban children. If you look at urban, it is 48% above the 5 microgram per deciliter, whereas in the rural areas it is 29% in the 5 microgram above the 5 microgram per deciliter. Children with BLL greater than 10 microgram per deciliter, almost similar, 4 in the rural and 6 in the urban. So mean levels, if you look at urban, it is 4.8, and rural areas it is 3.7. So then I also said, like, we also did pregnant mothers. That is, this pairing of mothers. The children should have been tested. If you want to test the results of mothers, we want to check it. So we had 76 little cases to look at their data, because we have only 76 samples overall. So if you look at this, 20% of the mothers are having higher BLL levels, greater than 5 microgram per deciliter. Other range 10 to 19, luckily we don't have it. The minimum levels 2.3 we have seen, and the maximum is 9.3 in the pregnant mothers. So we also did a risk assessment questionnaire, and this is risk determinants. Based on that, we did an analysis, and it shows that chipping paints, the pica behavior is like keeping the things in mouthing of paints or soil, all those things. Chipping of paints is 1.5 times more likely to have higher BLL, that is 5 microgram per deciliter. Living near a lead-related industry is 1.7 times more likely to have 1.7 times more likely to have an kind of exposure to the BLL, higher BLL, 5 microgram per deciliter. And finished floorings is act as a protective factor, 57% less likely to have the risk. So with summary, we could quickly move into summary. 39% of the children had higher BLL, greater than 5 microgram per deciliter. So our findings are also similar to some of the other studies published. All districts except Salem, which is rural, 1 in 4 children tested had elevated BLLs. So the elevated levels also you have seen in pregnant mothers, that is 20%. Multi-factors are linked to the BLL levels. It can be pica behaviors, that is chipping of paints or keeping things in mouth, and also living near hazardous industries, all those things are linked. Thank you. And this study is done in collaboration with the Vital Strategies, Pure Earth, and Director of Public Health, Tamil Nadu. And I thank them, the collaborators as well as the supporters. And I also thank my colleagues who are supported and the team that worked towards bringing these results.
That brings us to our last presenter in the session, last presenters rather. So it's Elizabeth Sefton and Casey Bartram. Liz Sefton is an Engineering and International Development Fellow at the Institute of Electricians and Electronic Engineers. She has a PhD in evolutionary biology from Harvard and completed a postdoctoral fellowship in human genetics at the University of Utah. She has developed models to study genetic and environmental factors underlying birth defects, including how chemical exposures disrupt organ growth and development. She'll be presenting with Casey Bartram. Casey Bartram is a senior scientist and executive director at TIFO, Terragraphics International Foundation. Dr. Bartram has a bachelor's degree in environmental biology and zoology and a PhD in environmental science. She has worked on human health risk assessments and interventions in mining recycling communities in Kyrgyzstan, Bangladesh, Peru, India, South Africa, Nigeria, and the US. She is a visiting lecturer at the American University of Armenia's School of Public Health and associate professor at the University of Idaho. Dr. Bartram is also a member of Collegium Ramazzini, an independent international academy of experts in the fields of occupational and environmental health. Liz, Casey, thank you.
Thank thank you so much for the introduction, and thank you to the conference organizers for having us here to talk about this project I've been working on with Casey and Brett. So as we've heard about today, lead exposure can come from diverse sources, from spices to cookware to industrial emissions. But in many places, there's not access to tools like isotopic source apportionment that can really identify which sources are driving elevated blood lead levels. Biokinetic models, like the All Ages Lead model from the EPA, are low-cost alternatives to estimate the relative contribution of different sources to blood lead levels. The model estimates lead absorption, distribution to tissues, and elimination with inputs from media like water, air, and soil. So you can use locally relevant environmental exposure data from field studies, and then using those measurements to model blood lead levels from specific exposure pathways, it can help inform which interventions might have the greatest health impact. So our goal here was to use the model to gather from different exposure scenarios and become a tool with lookup tables that can be used in the field or by governments to quickly evaluate different scenarios and help prioritize interventions. The All Ages Lead model was developed for US populations, and so there's some inherent limitations associated with that. In particular, it hasn't been evaluated extensively at high blood lead level concentrations. So here we reviewed the literature for data that are relevant to LMICs, and including regulatory standards as well as background levels and plausible intake rates to represent a variety of feasible scenarios. And so today we'll walk you through 4 different media that we looked at: air, water, soil, as well as cookware. So for air, in battery manufacturing and recycling plants, average airborne lead concentrations can be 350 micrograms per meter cubed. That's more than 7 times the US OSHA exposure limit. So we modeled concentrations from 0.01 to 350 and treated exposures at 5 or greater as occupational exposures. And this is a really powerful feature of the All Ages Lead model, is that it lets us treat these as intermittent exposures. And so even though these are really hazardous environments and are not safe for children, we did include both children and adults in our model, as there are contexts where people take children to work. So here are our results. So we've plotted average blood lead levels against air concentration of lead. And lines of different colors represent different age groups. And we can see that as occupational exposures increase, blood lead levels rise quite dramatically. And importantly, some of these values are consistent with what has been empirically measured, with averages in battery manufacturing and recycling plants ranging from 45 to 64 micrograms per deciliter. For water, we modeled from 0.9 to 200 micrograms per liter of lead concentration, and this includes the WHO regulatory standard, as well as levels that we've seen from leaching from hand pumps and materials like that into the water supply. We used age-specific water ingestion rates going up to the 95th percentile based on EPA estimates. And here we see that as total lead intake increases, blood lead level concentrations go up to around 30 micrograms per deciliter here. Soil presents a particular ingestion risk, especially for young children. We modeled concentrations in the soil from 19 to 5,000 mg per kg. 19 was the average background we found from looking at 14 countries with a focus on LMICs. And 5,000 is really high and is reflective of more of levels that have been measured close to smelting sites, for example. We used dust as a standard fraction of soil and used age-specific soil and dust ingestion rates. But that last variable in particular of ingestion rates of soil and dust is something that we think can vary quite a bit in LMICs compared to the US. So for example, in the EPA, those default levels range from 12 to 72 milligrams per day. But dust ingestion estimates in LMICs are much more limited, and those can be environments where people spend a substantial amount of time outdoors and maybe don't have finished or hardware or hard floors. But we did find one study from 2019 that was conducted in a mining community in the DRC, and this found dramatically higher soil and dust ingestion estimates compared to the US, especially for women and children, where averages were 3 grams per day, with a 95th percentile of up to 12 grams per day. And so we modeled ingestion from 20 milligrams up to 12 grams per day. And this is results looking at a constant soil and dust concentration of 200 micrograms per gram up to 1 gram of ingestion. And we can see that if the ingestion rates stay really low, below 100 milligrams, then blood lead levels stay well below 5 micrograms per deciliter. But as they go up, those blood lead levels climb quite a bit. And if we factor in those even higher ingestion rates, blood lead levels go up substantially more. So even at moderate contamination, we can see with high ingestion rate environments, it poses a significant risk. And then if we look at those more extreme concentrations, even with low ingestion rates, blood lead levels climb precipitously. So this shows how with high concentrations plus behavior, this really compounds risk. And I should say that in high contamination environments, these high blood lead levels have been observed in the field from 80 to 100 micrograms per deciliter. And with that, I'll pass it to Casey.
Thank you, everyone. I'm on team jet lag, so I have some notes that I have to glance at occasionally. I appreciate your patience with that. So as Liz mentioned, we also looked at dietary lead intakes, both from contaminated foods, specifically looking at adulterated spices, as well as from cookware. Starting with spices, we first developed intake tables, which of course are based on concentration and consumption. And we used concentrations ranging from 0.5 up to 1,000 micrograms per gram, based on what has been documented in the literature from LMICs and other settings. For a point of reference, this is inclusive of the current US FDA and Indian food safety standards of 10 micrograms per gram. We also had to determine consumption rates, which proved to be a little bit more challenging. We did identify several studies that looked at spice consumption rates. 1 gram per meal was the lowest spice consumption rate, whereas they went up to 28 grams of spice per day in some populations. But an important caveat here is that these consumption rates are for all spices used in a meal or in a day, and not just from contaminated spices alone. So in using these and developing our intake tables, we know we likely overestimated intake and therefore blood lead levels. The model output is shown here, and based on a review of the literature and knowing that we had likely overestimated intakes, we decided to cap predicted blood lead levels at 40 micrograms per deciliter. And this reflects the highest blood leads observed in children, attributed largely, although probably not entirely, to spices in Georgia, where some children had blood leads over 30 micrograms per deciliter. Lead in cookware includes both metal cookware as well as lead glazed ceramics. We did not separate these two when we did our intakes. Studies indicate that new ceramic cookware leaches more lead than metal cookware. However, leaching from lead glazed ceramics likely decreases over time, whereas leaching from recycled metal cookware is highly variable and, depending how it's cleaned, may actually increase over time. So rather than try and account for all of these variables, we decided to combine them in our analyses. Several studies have assumed a 250 ml serving size, so we took all of the available studies and normalized the concentrations in leachate to a 250 ml serving. The range of lead per serving is inclusive of the US FDA leachate standard for cups and metal hollowware, which is 0.5 parts per million, which converts to 125 micrograms per 200 ml serving. And we developed intake tables based on consumption rates that range from 0.25 up to 2 servings per day. After looking at the model outputs similar to spices, we decided to cap blood lead levels based on a review of the literature where biomonitoring data were available that were associated with cookware exposures. Most of these studies looked at blood leads associated with lead glazed ceramics. And the highest blood lead level we could find from lead glazed ceramic exposure was 53 micrograms per deciliter from a family using Mexican lead glazed ceramics. So we capped our blood leads at 50 in this analysis. We wanted to quickly mention that we considered including modeling blood leads associated with lead-based paint. It's well established that blood leads are strongly associated with with indoor dust concentrations, as has been discussed in other presentations today. While it's known that lead in dust is influenced, certainly, by lead-based paint, that's also heavily influenced by coverage area, by the condition and the age of the paint, and other factors. And ultimately, we were unable to identify or develop an appropriate method that would approximate an exposure value based on a lead paint concentration. So we did not include that in our analysis. In summary, these results present a low-cost method for prioritizing interventions based on environmental or source data. These results will be lookup tables that can support locally tailored interventions and prioritize actions in a population. We, of course, recognize there are limitations in this analysis, including underlying assumptions that can both over or under predict blood lead levels. But despite this and these uncertainties, this is really a tool that can be a practical one and useful for a variety of stakeholders. Importantly, this approach can be validated and modified over time with results from ongoing research, probably by people in this very room. And we especially are interested in the performance of the model at higher exposures and blood lead levels. We are in the process of finalizing this analysis and then writing a manuscript, so this is a really great opportunity for us to receive feedback from everybody in this room, and we look forward to ways that we can modify and improve this analysis moving forward. Finally, Liz and I were at USAID when we started this project, and Liz and Brett and I, who are all working on the project, are really grateful for support from individuals at USAID as well as at EPA and to our respective organizations as we've tackled this over the past year, which has been a little tumultuous, as it has for many. We also want to acknowledge Brett's previous work with lookup tables on the UNICEF toolkits and that we're building on that contribution as well. So thank you all very much.
Okay, so good. So we'll start with some questions. I have a few questions, and then I think we have 15 minutes, so I'll try to, if we could do these quick, and then we can get some of the audience questions in. So we've heard we've heard about assessing capacity to go out and do these blood lead tests. We've heard about this effort to go out and do them, and then we've heard about predicting what blood leads might be based on various environmental media. I'm going to start with Dr. Vinaya Gamurthy, who's done this. I mean, frankly, a very large study. 700 children is not a small logistical feat, especially when they're randomly selected. So I'm curious about, I mean, in an ideal world, we would be able to do, monitoring, or at least some sort of random study of children to assess what blood lead levels might be in a given geography. Can you talk to me about some of the challenges that you encountered doing this study? And why can we not just replicate this over and over and over?
Challenges, of course, we have faced rejections, specifically urban areas. We have seen more of rejections, and the capillary blood is fine, but then when we go for the venous blood sampling, parents are not happy about it. The moment we are drawing around 3 ml of blood, they are worried about it. So one of the major part of it. And then, the more rejections are into when the phase 2. This is the phase 1. We have seen the phase 2, and which we not presented it. Phase 2, which we have to assess the home environment, like paint, households, cookwares, spices. More of rejections, because almost you have to spend 1 hour, 1.5 hours in their home testing all those, and the soil around, someone has to be there. So phase 2, we face more rejections than the phase 1.
Thank you. My next question is for E, and Dr. Vinaya Gamurthy to some extent. So I'm curious about the lead care. It's got this lower detection limit of like 3 or 3.1. And I'm interested to understand how when you present a mean blood lead level, how you're using those results. I'm interested to understand what you think you might be missing by using that. I'm also interested in hearing about are these results adequate to influence policymakers? And then finally, I guess, and I'm going to start with E, I'd like to hear a little bit about risk communication. You're taking blood leads. How are you communicating these results back to the families? And how, particularly with that environmental data? How are you communicating the risk and how they could possibly mitigate their exposure? That's a lot. I'm sorry. I'm just very curious. But I'm sure E is very capable of answering this.
I'll kick it off, but I think Dr. Vinaga will have more to share. So I think, yes, there are a lot of limitations of lead care, the detection limit, the detection range, the higher kind of potential vulnerability to field contamination. I mean, we have trained, we're currently in the field, Yatin is leading our work in Maharashtra and in Indonesia. We're also seeing that even though it's a portable analyzer, and we think it has a fairly easy procedure, but it's much harder to train the health workers to follow it through. A lot of times, we need to wash the kid's finger with washing and soap water, but many of these stations are so remote that they don't even have running water access. So we're aware of the limitation of portable analyzers, but I think this question also comes to what is the alternative. So alternative is that we draw venous blood and then send them to a laboratory. So that's one of the things that in most of the countries that we conducted this assessment, we have not seen there's adequate testing capacity in the sense of in Kyrgyzstan, there's none. National laboratory, and the costs are generally very high. And then here we talk about 500 microliter to sometimes 1 milliliter of blood. But in many of these countries, even when they have laboratory, they're asking for 4 milliliter to 5 milliliter of blood, which is a lot to draw for the children that we're focusing on, which is under the age of 5. And I think that touched on how the refusal rate is. So. So I think there's some limitation that we're definitely being aware and then trying to do more training and more protocol development to minimize the environmental contamination. That's what we're mostly concerned about, the capillary testing with the lead care or the portable analyzer that we are mostly available now. So that's some of the limitations that we're aware. Just to answer, I think I can leave some room for Dr. Vinaga. Answer the question of how much we can see still with the impact of data coming from lead care in most of the cases, right? So first of all, I think the engagement of government and then to help them to take ownership of the data is very important. I think that speaks way more than what type of measurement you're using. It's actually engaging them in the design and discussion of the data. And that itself raises the impact of the data a lot. So the other thing is that we also do validation. So when we are entering a country, first of all, in our capacity assessment, we look at whether there's previous BLL studies have already used it and whether it's validated by some of the studies. And we then still do a subset of the samples for venous blood to send to the laboratory. So that also gives some confidence in the results. So I think all of these are building the confidence for the government to take in the data, but it's more for establishing ownership of them with the government. I think that's what makes the biggest difference.
Fantastic answer, you. Thank you so much. Dr. Vinagamurthy, can you add to that? Could you also speak a bit to risk communication and how the results are communicated?
I would just first answer your question on the contaminations part. So what we did was CAM-based assessments, what we have done. Some, for example, the Bihar, they have done it home-to-home assessments where there are possibility of contaminations. But then here we did mostly in the CAM-based method. We did it in PHCs or community settings. We have done it. Coming to the risk communications, we have informed as per the protocols. We informed the lead levels. We also have one set of information that we provide to the families, how they can avoid the lead contaminations, where from it is coming. That is the information sheet we provided. We also provided that also tells about the risk factors. What are the risk factors there? For example, pain, cookwares, all those things we are giving. And also by ethics, we also provide the BLL levels to the parents. And if it is a little higher, we also give counseling. We provide counseling.
Thank you. So my last question is for Liz. So these biokinetic models are really powerful, and they've been validated, at least in the US settings. In many parts of the world, we have pretty good environmental data. We've gone out with XRFs, or we've sent stuff to a lab. We have all these environmental data. in the absence of blood lead surveys, and I know you focused primarily on source attribution, but in the absence of blood lead surveys, are environmental data, in your view, coupled with these BioConnect, with the all ages lead model functionally, adequate for predicting blood lead levels? And if not, why not?
Yeah, I think at the very least, I'm comfortable saying it's a valuable and worthwhile starting point. And there have been studies comparing, especially like IUBK in places like China and Malawi, and in some places there has been really good concordance of these models, and in others, like in Malawi, the concordance wasn't as good, and it overpredicted a little bit. But at the same time, I think in terms of trying to map out high-risk areas and what you should be looking at first, I think it is. I think using them is more beneficial than not.
Thank you. So I'll open it up to the audience. I think we'll have lots of questions. We have lots of time, so please ask questions. I know enough people. Well, I will just call on you if you don't ask questions. I'm going to start with Dan Cass.
Thanks for those. Those are great. So a question to bridge the two sort of types of presentations. So the results you saw from Tamil Nadu, and I think they've borne out in other ones, demonstrated that the effect that we see typically in surveillance data in the United States of declining lead levels with age, especially from a peak of 2.5 down to sort of the age of 6, they're pretty profound and consistent here. But we're seeing data that suggests elsewhere that blood lead levels rise or don't decline over the first 6 years. The modeling results demonstrate clearly that they should from these sources, presumably because of both metabolic changes, but also the likelihood of ingestion. So how do we make sense of this, do you think? Like, what can we learn from the sort of discordance between the prediction and the observation on those things?
I guess I'll take one more question. Otherwise, I'll forget, and then we'll go back to you guys. And I'll take.
Hi, I have a question regarding the lead care. Because if you think of the lead care, which has a limit of detection of 3.3 micrograms per deciliter, and if this now is the standard in low and middle income countries, that is still 3 times higher than or nearly 4 times higher than what's in the US, but we have the lead levels. So is that something you would encourage governments in low and middle income countries to invest then in the future in laboratories which can do better monitoring? Because I feel like if you drop below the 3.3, everybody might think, oh, that looks good. We are below that, below the limit of detection, so we are great, but we are still way higher than in a lot of developed countries. So what would you do in the future, maybe in your program, what you have right now?
So I guess we'll just go straight into the answers, if that's okay. And I'm going to start with Liz on Dan Cass's question about the curve of the exposures and how and why is age captured in this, or how is age captured in this?
Yeah, I mean, we see definitely that younger ages are more susceptible to these higher blood lead levels, and that's reflected in the kinetics of how it's absorbed. In terms of discordance, I think there are, of course, with the caveats and limitations, there are several variables that I think are important to mention and think about when considering discordance, and that's one is bioavailability, especially in soils, and different types of soils can have different bioavailability. For example, something that Casey touched on in food is estimating consumption rates and the challenges associated with that. So that was the one media where we had to kind of cap because we were getting blood lead levels that were higher than what we might expect. And so thinking about how are we accurately looking at that. So I think having an active feedback between what variables we adjust in the model with these measured blood lead levels is critical. And also, another thing I should mention is nutritional status as well. And if you're not getting enough food, there's evidence that you tend to absorb more lead, and especially if you tend to be calcium deficient. And that was not factored into our modeling at all. So that's another important element to consider as well.
Could I ask you to build on that a little bit, particularly with regard to, I mean, you've done so much work with surveys, of surveying behavioral characteristics of given communities. Talk about that and how that might influence the modeling, or is that?
Well, that's something we're trying to learn through our studies in different countries and to understand a little bit more about the nutrition status, but also how the pick-up behavior, and then also whether the children may have more diverse exposure from outside of their home kind of environment. I think that's what we're trying to address in future locations.
And Dr. Vinag and Murthy, I'll turn to you about this question about the lead care and the limit of detection of 3.3, if you could expand on that.
3.3, yeah. So that's the limitations which we have. But this is a point of care testing. So when you want to do a large scale sampling like 700 and 800, if you want to go for ICP-MS, we need to draw 3 ml of blood, first thing. And then the second one, as I said it, when you go to 1.1 and to 6 years, 1.1 to 6 years is small kids, and when you're going for 3 ml, it is more of rejections what we are getting. First, we need to understand the distribution, how much this thing. Then we can move on to the next levels of testings, and then clinically how to prevent this, taken interventions, how it works out. So first to understand is the surveillance point of view. I think the LEDCare-2, what the results comes is good enough. For us, for the other analysis, we used 2.6 for the modeling part. For the published papers,
I think 2.3. Yeah.
2.3 we use for the analysis purpose from the published studies. So I think at a point of care instrument that has limitations.
We have a bit of time. I do also want to respond to Catherine's questions. I mean, in a way, even in the U.S., in some of the states, the LEDCare are still being used, and in many of these countries, it's either no data versus you have data. And then laboratory capacity building, which is we are also working on with many of the laboratories in the country, does take a long time. They don't. Sometimes their barriers are so basic that they don't even if they have the laboratory, they might not have stable supply of the reagents, and they run it for a while, and then they stop running, and their machine broke down, and then they might lose their trained technical staff. So I think there's a lot of challenges, but of course we're trying to build both as well. But I do think when it comes to whether you can screen some high-risk children and they might be at a very high level, if their trade-off is no data versus you have some understanding, I would say get the data.
Yeah. So I think we have time. We have time for 2 more questions. So I'll start in the back of the room.
Yeah, thanks for the presentations. Very, very informative. I was just curious about the use of the LEDCare as it's used as a confirmed test, or is there some ability to do like confirmation with another method, especially if there's a high blood lead level?
Okay. And now we have time for 1 more question. Neither.
Thanks. The study in Tamil Nadu and the finding the protective nature of flooring, having a finished floor was quite interesting. Is this something that's been studied widely, maybe others? Because if in fact you can get a 57% kind of protective effect, that might be something to think about. And then if so, why? What are your theories there? Is it cleaned more, et cetera? So I'd love to hear a little bit more about that.
We can have 1 more. I think we have 1 more up here. We'll probably just bring it in the wire. Everybody wants to stay a lot longer, so.
Yeah, I just want to add one research question with regards to the exposure of children. It's not only direct exposure from the environment or soil or anything, but there is direct transmission, intrauterine transmission from their mothers. Did you study the childbearing mothers' occupational exposure, and if they have given birth while they are working there? And did you also research on the blood level of those children? Because there are different ways of exposure for children, if you see that. Thank you.
Thank you. So I think all of those questions are for Dr. Vinag and Murthy, and perhaps he, would you like me to recap them, or you just? So the first question has to do with what was the purpose of the LEDCare sample? Was this was the study, or was this just a a few samples and then they were all confirmed later in the lab? Or did you do a smaller percentage back in the lab? There was a question from Neither Parks about the impact of fluorine on children's blood lead levels. And then the last question is about in-uterine exposure, so from the pregnant mother. So you studied pregnant women, so perhaps you could talk about those three things. And I think you have a minute or two to cover that.
Yeah, so question number one, and then it's again with regarding the LEDCAR2. When we didn't go for the testings the next, so we have utilized only the capillary blood testing, but here they have used the venous blood testing, and there is very minor differences between the LEDCAR and the ICP-MS. So that's, I think that question, did I answer that question? Okay, the question number two, for the pregnant mothers, we although paired the samples, right? So as I said, when the children's is tested and his or her mother is pregnant, then only we tested it. But then we didn't go ahead with the occupation assessments. Again, these are all the questions that we asked. What we are looking at is the one is like self-reported answers, right? So we have a risk assessment questionnaire, and they answer. Is there any industries, risky industries nearby? If they say yes, then we cover it up. And are you working in, parents are working in a occupation related to battery or recycling? Yes, if they say, we record it. So this is again a self-reported one. So we have not went ahead and then checked the next levels of things. Maybe it's a good one to go ahead with next set of studies. They can assess that part. The third one.
About pregnant mothers, transfer of lead to the fetus. Did you evaluate that at all?
No, we have not done that. Maybe we have to do the analysis. Yeah, thanks for the question. We'll do analysis and see, because we have a limited set of numbers. Only 78 pregnant mothers we have. And whereas the children's, we look at the 713, we have children's. So we need to see. We do the analysis part, we will see that. Thanks for that.
Yeah, of course.
I'll just add one sentence. We did do in our Bihar study before, we did validate the venous blood sample versus capillary, and then we did publish our the correlation coefficient and the average differences in the paper. So it's not ideal, but I think we have seen in validation studies before in the field, there's a range of how strongly they are correlated. And in our Bihar study, we also seen a moderate correlation between the mother's BL and then the children's. But I think there are many other cohort studies that answer this question better.
So if I could get a big round of applause for our panelists, thank you very much.
All right, fulfilling now my favorite job as MC, which is to invite you to join us for a reception outside. This is our final panel of the day. So please do join us for a drink and snack. We'll also be reconvening here tomorrow morning at 9:15 for the first session of the day and a full agenda of more great research. So thanks everyone, and we will see you outside and tomorrow morning. Thank you.